welcome everyone. And I would like to welcome those who are in this room and those who are joining us virtually. I'm Dr. Ifat Al-Barazi. I am an assistant professor here at the Institute of Health in the College of Medicine. Thank you very much for coming today, and welcome again on behalf of myself and on behalf of the IPH, the Institute of Public Health team, and our colleagues. So as you can see, we are going to have this workshop for nearly 4 hours, and definitely I would like to welcome our guests who are joining us today from Canada and from Lebanon and from Dubai. So I just want to, before we start, to remind you, if you need any help, we have our team outside at the registration desk if you need to know to navigate in this college, which I'm still lost usually in this college. So if you need any help, our team will help you. Please remember, if you want to ask any question, to open your mic, because we are recording this and we want our virtual attendees to hear you. Please, if you want, it's up to the speaker to make the discussion and to allow you to ask questions. But please, if you need to ask question, just raise your hand. And those who are joining us on Zoom can also use that raise hand feature, and we will allow you to speak. So I just want to go through the program today, because there was a bit of change in the program that we have shared with you before. So quickly, just to let you know that we will start now with an introduction from Professor Michael Grivna, and I'll introduce him, and then Dr. Mohammed Al-Sadiq, who will be speaking about health economics, and he will tell you about our EHTA unit, which is launched today. And then we have Dr. Fatma Sayyah, who's joining us from Canada, and she's here physically, and thank you very much for her presence. She will talk about the study that we are going to conduct here in the UAE on value of health. And again, I will introduce her, and then we will have a coffee break. And you will see that there will be refreshments around 11 o'clock. We'll be outside for coffee, tea, and a bit of just snacks. And then we will move to Dr. Mirna Matni from Lebanon also, and from the CCHO office in Dubai, and she will be discussing with us also the HTA practices. And then Dr. Asara Dalal, the head and the director of the Health Economics Society, will join us virtually, and hopefully she will give us also a brief introduction to the society and what are their plans. And then we will have a kind of short discussion, panel discussion with our speakers, and you will have the time to discuss and ask them questions. And then we will finish our, sorry, I just need to put this on silence. So let me start to introduce Professor Michael Grivna, who is going to say that to welcome you and to start this program. So Professor Michael is like, if I want to speak about Professor Michael, I will take the whole morning. Professor Michael is the director of the Institute of Public Health. He is someone who has a long experience in injury prevention, in public health. Professor Michael is a leading expert actually in injury control and safety promotion. His research includes topics in childhood, adolescent injuries, school safety, traffic safety, baby walker injuries, child vehicle protection, playground injuries. So he's got a long experience in child injuries prevention, and one of his contribution to the UAE, that was the program that has been implemented by the Department of Health on child seats in the cars and baby walkers. So Dr. Michael has been in the college for long years, and he has been directing the Institute of Public Health for more than 4 or 5 years. And if you want to know more about his expertise, I think he can speak about himself more. Please, Professor Michael, please, the microphone is yours, and thank you so much.
Thank you, Dr. Ifat. So it was very kind of you, and not necessary to speak about me. Today we are really all waiting for a very interesting webinar. So dear colleagues, ladies and gentlemen, dear online participants, we should not forget you, that you are many on the online. Welcome to the College of Medicine and Institute of Public Health. I would like to welcome you all, especially on behalf of our Dean, Professor Jumal Kabi, and our also Assistant Dean for Research, Dr. Rami Beyram. As you know, one of the 17 Sustainable Development Goals by the United Nations, and specifically this number 3, is related to good health and well-being. And unfortunately, despite all efforts to promote healthy lifestyle in many countries, including UAE, there are still excessive budgetary resources spent on treating illness that could otherwise be prevented. And the healthcare costs are increasing over time. We all know this. The continuous discovery of new health technologies, including new therapeutics, which cannot all be simultaneously acquired. So it is incredibly expensive for the countries, even in rich countries, without analyzing the cost effectiveness of these new technologies to make an informed and cost-effective decision. The World Health Organization defines health outcome measure. So today will be a session about the outcome measure and how we can measure the health outcomes. And the quote is, the change in the health of an individual group of people or population attributable to a health intervention or series of interventions. The traditional approach for evaluating outcomes use variables such as mortality, morbidity, disability. We call them more like traditional units. And the time has come to consider the quality dimension. And this is very important. The quality dimension, the quality of health and healthcare in order to improve healthcare outcomes evaluation. That is possible if we undertake effective economic evaluations of new health technologies, which consider both the cost of the new technologies on the one side, but also health outcomes on another side, using state-of-the-art generic measures, for example, the quality-adjusted life years. And today we will hear a lot about these measures too. Healthcare outcomes improvement cannot happen without effective outcomes measurement and appropriate cost analysis. Economic evaluation contributes to evidence-based decision in countries, or should be based, or should somehow fill this economic-based decision-making, especially if the health sector must address the health needs of very diverse populations, like we have in the UAE, with a constrained budget and shrinking funds. This is why today's seminar is so timely and important. This finish of my speech. Thank you all for coming. I would like to thank Dr. Mohammed Al-Sadiq, who initiated in some way all these activities at our college and at our institute. He's head of the newly established Emirates Health Technology Assessment Unit. I would like to thank also Dr. Ifat Al-Barazi and Dr. Azad Talal and other colleagues from the Institute of Public Health who organized this seminar. I'm delighted, really, that our invitation to speak at the seminar was accepted by international experts who are here today with us. Dr. Fatima Al-Sayed from the University of Alberta, Canada, Dr. Mirna Matni, Senior Director for Health Policy, the Center for Clinical Health Economics and Outcome Research, and Dr. Salah Dalal, President of the Emirates Health Economic Society, who will be connected with us online, as I understand. I'm also pleased that we have participating colleagues from health authorities and other academic institutions. Welcome again to our college, and I hope that seminar will be very interesting and beneficial.
Thank you very much, Professor Michael. So let me introduce Dr. Mohammed Al-Sadiq, who is going to speak to us today now about the EHTA and health economics in general. Dr. Al-Sadiq is a health economist and is a lecturer at the College of Medicine and Health Sciences at the UAE University. He's a visiting professor at the University of Robert Gordon, Scotland, and adjunct assistant research professor in epidemiology at Giddings School of Public Health, University of North Carolina, Chapel Hill, USA. He is a member of ISPOR, and his research interest is health economics and public health epidemiology, injury prevention, and safety. Dr. Sadiq, the floor is yours, and this is
Yes.
You prefer this?
Thank you.
Yes.
Good morning, everybody. Thank you for coming. Good morning to participants, online participants. Again, I would like to thank our international collaborators, Dr. Fatma Saleh and Dr. Minna Matni, and online, Dr. Sarah Al-Dalal, and everybody joining us today. Yes, whatever I say about our collaborators, I think is still going to be short, and I may not have enough time, and may not be able to reflect the way I want and I should do. Anyway, I think through the day we are going to have enough chance interacting with our partners and collaborators. And I think that is going to shed more and more light about EHTA, health technology assessment, and health economic evaluation, and so on. So I think I have to start with my presentation because it is going to be a bit long, and I'm afraid that time may not have. 20 minutes, okay, I'll try. The last. Right, my talk is on, okay, yeah, the pointer, thank you. I'm going to talk about health economic evaluation and health technology assessment. I'm going to start introducing first health technology assessment, and then I will move to also introduce in details the methods of economic evaluation before I conclude by talking about our new unit, functions, scope of work, and so on. Let us start. Right, let us start by defining what health technology is about. What do we mean by health technology assessment? Health technology assessment is a form of systematic evaluation, okay, of the scientific evidence and the cost effectiveness of new health technologies. As we all know, and as hinted by Professor Michael Grivna, health technology assessment is so well needed, and we are going to understand more and more about that through my presentation and the following presentations, okay? So the process is so important for the healthcare authorities, especially when considering adopting new health technologies. I will explain a little bit about what we mean by health technologies. Maybe it's a bit new to many of them. So the approach helps to decide whether a new health technology is worthy, is good value for money, or in other words, is cost effective. Sorry. If you can move there, so those who are on virtual can move. Oh, I see. Okay, I didn't realize that. So yeah, the important consideration here is to make sure that the new health technology is of good value for the investment, for money. Or in other words, in health economic terms, is cost effective, okay? Cost effective for the healthcare system, for the population, and so on, right? So the process of health technology assessment allows comparing different policies, different treatment scenarios, and so on, especially the new ones under consideration. From academic point of view, EHTA is a form of research to generate information about the clinical efficacy and effectiveness and the cost effectiveness of new health technologies. These are two dimensions which are so important for decision makers, as we know. Now, the question is, what are these health technologies we are talking about? Health technologies is a broad concept that include medical products like medicines, even biologics, medical devices, equipment, and medical supplies, surgical procedures. Also, it includes policies and public health programs and support systems. Any intervention one can think about, okay? It's all considered as a health technology. Why is it essential? Why the health technology is essential? And why the interest in health technology assessment is growing? These are really important questions. From my own observation, following COVID-19, the interest on health technology became increased, and this is due to the fact that the costs of running healthcare services have become really very alarming. And this has been the same, whether in the rich countries, developed countries, or middle-income countries, or the low-income countries. All countries now in the world are really suffering from the economic setback that was triggered by the COVID-19 pandemic, and it is affecting everybody, and of course, on top of that, affecting the healthcare sector. Healthcare sector is usually between 20 to 30% of the national economy everywhere, in most countries. So it's a very sizable, and even at the household levels, it is a huge burden. And any shock, any big issue, problem like the pandemic of COVID, of course, is going to adversely affect the performance of the system. And that's why it is so important to think twice whenever making any decision in relating to healthcare expenditures these days. The WHO estimate that 20 to 40% of healthcare budgets are actually wasted each year as a result of the inappropriate use of medicines, inefficient resource allocation, and the weaknesses in the healthcare functions. So what is the scope of health technology assessment? The process and is trying to answer, is usually attempt to answer some related questions which are very essential, as I said before, for decision makers in the healthcare sector. First, the impact, the economic impact of new technologies, new drugs, and so on for patients and the population, right? There is always responsibility by Minister of Health, by the higher authorities, and they have concerns, so many like competing concerns, not only the healthcare sector, of course, they have other concerns, and including the healthcare sector itself. And also within the healthcare system, it is always important to learn about the impact any new intervention will leave on the available healthcare resources. So this is another question. And the third is the social and ethical implications of the new technologies, new interventions, new policies on the target patients population, okay? So, regarding the process and methods that we use in for health technology assessment, they include that to determine what knowledge. First, we need to determine actually what knowledge is important regarding the consequences, the effects of using the new technology, and what effects are really matter for the decision maker. That is one. And so on top of that, of course, we have to prove that the new intervention, medicine, whatever, is clinically sound and effective. And of course, there are well-established procedures by FDA and so on to prove clinical effectiveness. And usually the clinical effectiveness is published. So it is, but of course, still we have to do the research reviews and meta-analysis and do our job. Second, we have to look onto the ethical considerations, and more important, the cost effectiveness of the new therapeutic. And from the perspective of the healthcare authority, we need to know also the budgetary impact. So the basic steps for health technology assessment include some of these 9 steps. First, we need to identify the topic for assessment, specify assessment problems or questions, and then retrieve the relevant data to generate evidence, generate or collect new evidence whenever appropriate, appraise, interpret quality of the evidence from the literature using appraisal forms and so on, integrate, synthesize evidence, formulate findings and recommendations, and then consider disseminating the findings and the recommendations, and then monitor the impact through time. Okay, these are very important steps in health technology assessments. And learning from the experience of health technology assessment agencies, most agencies require evidence to address multiple issues, including the burden of illness, the projected epidemiological trends of the disease under question, relative effectiveness of the new health technology, and the cost effectiveness of new health technologies, and how patients value the outcomes of the new health technologies. Most of these steps could be negotiated and discussed ahead of time with vendors and with manufacturers. So they supply us with a lot of data concerning this, because as you might know, discovery of any new therapeutic, any new procedure takes years and years. And before and after, there are lots of studies, and manufacturers tend to share the evidence publicly. So there is a lot of data available. The data sources, there are 2 main types of methods relating to data. We can do the analysis from primary data. So means that we have collect primary data and use primary data analysis methods. And also we can work from secondary data, secondary or integrative methods, methods that we can retrieve from published data. So the primary data methods involve collecting original data from clinical trials and observational studies. The integrative methods or secondary or synthesis methods involve combining data or information from existing sources, as we do in meta-analysis, including from also primary data sources. And in addition, the other source of interest to people like me is economic analysis, economic data from economic studies. And it might also involve collection of new data, like when we have to produce estimates for the budget impact, okay, of the new technology on our budgetary resources. This is usually required by the healthcare authorities, and it is of utmost importance for them. Of course, they need to know also cost effectiveness. In some cases, the agency or EHTA body may answer some of the questions directly or by commissioning also new research. There is a database from the international agencies for health technology assessment, like EHTA, the Health Technology Assessment International. That's another European-based agency. There is a European also agency, and so on. There are really many agencies working in close collaboration with pharmaceutical industry, and they do a lot of work. Okay, so and they share information. Okay? And they constitute really a very good source to provide relevant information. I have 5 minutes. I don't know what I can do in these 5 minutes. If you give me another 5 minutes. This is a very big presentation. In practice, most agencies rely on integrative data, and well, it is by and large the process is process of distinguishing between the strong evidence and the weak evidence. Okay. After we do our job, then we have to disseminate findings. This is what this slide is telling. And dissemination of findings, you know, it could be by publication in peer-reviewed journals, or it is sometimes we have to communicate directly with the party or the agency or the authority commissioning the research, and so on. So, but the findings also are subject for publication. That's the end of the first part. So anyway, I'm going to give an overview of economic evaluation. This whole seminar is about health economic evaluation. Preeta sitting at the end knows how big is that, and so got help. Anyway, I will try just give a snapshot. It may not apply to everybody, but make it easy. Yes, that is how this cartoon is really very informative. It shows the state of the world, decision-making without decision-making in healthcare without any like system to prioritize and decide about priorities. So the departments or possibly the sectors who have bigger muscles will be dominant, and they can reach to the resources available, like big pharma, like drugs industry, and so on. And the short and weak, like preventive medicine, public health, may not really reach for anything, or just rely on the spillovers somehow. The resources in healthcare and in any other field of human activities are actually very scarce. Resources are scarce. We are living in scarcity, and that is how we have to start anywhere. There is nothing called rich country that can reach for everything, rich individuals that can reach. We all live with limitations, and we have to accept and live with that. So some order. Health economics is trying to bring some order to the healthcare system in terms of making the best out of the available healthcare resources, okay? And the way for that is by health economic evaluation. So that is the definition. Now we know. Michael Drummond, everybody knows Michael Drummond, especially those in the field. I think he was in Dubai last week. Some people had the pleasure to meet him. He is most prominent on the field, and his definition for economic evaluation is that it's a process of systematic identification, measurement, and evaluation of the inputs and outcomes of the alternative activities, programs, and the comparative analysis of these alternatives. This is a very comprehensive. Each word in this definition worth a book. Okay, so yes, through the process, we try to identify the best course of action among alternatives. And having said that, we have also immediately said that the approach of health economic evaluation is not actually a substitute for decision-making. Decision-making process goes by other ways as well. And that is, in fact, how it is managed so far. The tool of health economics evaluation is useful to clarify the choices in a rational decision-making process. Economists know this. We consider every decision-making rational based on the fact, the assumption that people act rationally most of the time. It is thus a tool to compare programs. It provides a systematic way to identify measures. We have said all that. So why we do conduct economic evaluation is to inform decision and decision makers in the healthcare field about interventions, which one is sound and so on, and evaluate which intervention is worth implementing among others. Evaluate also whether the benefits from implementing interventions are worthy, ensure that society can receive good value for their money. So what is the relation, economic evaluation and health technology assessment? Actually, health economic evaluation is a backbone of health technology assessment, because it is the only way to answer the questions we already mentioned. Let us just focus a little bit on the economic evaluation methods. There are generally partial economic evaluation methods, and which are more common and in common use. And also there are full economic evaluation methods, and among them, the most important is the cost effectiveness and the cost utility analysis approaches. I will talk general about this, and I think I will leave Dr. Fatma to elaborate more on cost utility analysis and the value sets, the EQ5D, 5L value sets, and why they are needed in terms of economic evaluation. These value sets are very important, and I think that is a very big step forward for the UAE starting this project, which Dr. Fatma will elaborate about. So I'm just setting the stage for her. Of course, partial economic evaluation, they are the most common, as I said, and they are called partial because they consider only the cost side. Analysis based on costs alone, I don't consider it economic. They are accountancy calculations or whatsoever. They don't really do or reflect anything. They don't add any knowledge, or they cannot help decision making in any sense. But of course, we know that most healthcare sectors, they have their accountants, and that is the data they have. In terms of outcomes, nothing. One of these is a cost. One of the methods in common use is a cost minimization approach, and this is very common. It's in common use, really. And using costing, we can still produce some evaluations. Here is an example produced by using the cost of illness approach. That's a costing methodology. And the evaluation found the following for a vaccination interventional program. So against an expenditure of 7.5 billion for the population under analysis, the outcomes were as follows. There were 20 million cases of disease that have been prevented by the vaccine, by applying the vaccine. And this could result in a savings of 76.4 billion in medical costs and productivity losses that will be avoided. And the intervention also will save 42,000 premature deaths. Very worthy. Still we can do. And still it is going. 2 minutes, she's saying. Right. Still, well, we haven't even considered the full economic evaluation methods, but they are here. They include benefit cost analysis, cost effectiveness analysis, cost utility analysis, and cost minimization analysis. They are all summarized here, the 4 methods. And you might notice that in terms of costs, I think they all use monetary units, but the difference comes in the way they measure effects. Okay, cost effectiveness use natural units for measuring effects, like years of life gained and additional life years and so on and so forth. Cost utility analysis is one under our consideration, and it uses utility measures, uses quality adjusted life years, and also it uses a bit crude method of DALYs, disability adjusted life years. Cost benefit use money for cost evaluation, and also again money for estimating the benefits. And cost minimization is same like cost effectiveness, using effects, considering effects are equal. The cost effectiveness, let us just consider this slide. It's considered the full economic evaluation. So it considers both the costs and the consequences. As I said, outcomes are expressed in natural units, and the objective is to compare program costs and program outcomes. And the choice goes to the one with the lowest cost per unit of effect compared to similar alternatives. Here is a figure showing that we have intervention A, B, C, and as I said, the choice goes to the most cost effective. And then we have cost utility analysis. Cost utility is similar to cost effective. It is actually another version of cost effectiveness analysis. The difference is on the measurement and the evaluation of the effects. And as I said, Dr. Fatma is going to cover that properly. And that's why we teamed up to introduce the EQ5D5. She is going to explain that. Dr. Ifat, I'm coming to the end, okay? But I'm leaving for you more and more slides. I think on cost benefit analysis, the same idea. Costs are, we already mentioned, but here are the details, okay? More details about each of these costs. The procedures for evaluation include identifying the inputs and the costs and the consequences of the program. Measure inputs and consequences using physical units, and then putting value in inputs and outputs or outcomes. But of course, we expect to have problems. Cost items may not be easily reachable, and the measurements and may not apply to everything, and so on. Having completed the analysis, we have to use discounting and sensitivity analysis. The reason for that, because the cost elements and even outcomes, they take place in, and especially for chronic diseases interventions, they take effect in years and years in the future. And as such, we need to discount these future effects down to the present so that we make the comparison we need. So in conclusion, because resources are limited and scarce, health economics is there. And it is the objective is to determine what medical services to produce, how they should be produced, and who should receive them. And as we have seen, full economic evaluations can be applied to healthcare to drive valuable insights about our healthcare. There is a little bit here, the one slide possibly about the objectives and functions of our unit. So we should not really forget that. And of course, we in the department, IPH, recognized that we have to introduce the concept to support decision-making in the UAE. So we have the expertise, we have a full battery of researchers, experienced researchers who can do this, whether in health economics, public health epidemiology, biostat, evidence-based, qualitative analysis, and systematic review, and so on. We are not short, really, of expertise. We have also collaborations, and our colleagues here from Alberta, where EHTA is hosted, I think are with us here. And so we are in good shape, although we are just beginning So our unit will undertake a systematic review and evaluation of the scientific evidence of all new health technologies that presented to us, and will attempt or try to work in collaboration with the local colleagues and also international agencies and experts. And we hope to produce practical recommendations for the UAE healthcare system. This is our department and experts, and these are our appraisal systems. And what else? And these are the major steps that we will be using for undertaking our work. Thank you very much for listening.
Thank you very much, Dr. Saleh. Can you hear me? Yes. So thank you very much. So it's not about money only, right? That's so I'm glad that I'm part of this unit, and I'm glad I'm part of this whole function. And let me introduce Dr. Fatma Sayyah. We already, please, took some of your time, but we will make my job a lot easier. Let me just get out of this one. So Dr. Fatma, I'll leave it to you to upload your slides if you want. So just let me introduce you. So Dr. Fatma is a health outcome researcher at the School of Public Health, University of Alberta, Canada. Her work focuses on measurement of patient-reported outcomes and quality of life and their application in population health assessment, clinical practice, and economic evaluation. She is a principal and the lead of the patient-reported outcome division at the Center for Clinical Health Economics and Outcome Research, CCHO, a consultancy firm based in Beirut and Dubai, serving the MENA region. She's also a member of the Eurocall group, where she serves as a on multiple committee and working groups. Dr. Sayyah has over 60 publications, and she's the associate editor of the Quality Health and Quality of Life Outcome Journal, and regular reviewer for other journals, including Quality of Life Research and Value Enhancement. Please, Dr. Fatma, we're so honored to have you here, and the floor is yours.
Thank you. Let's see, so we get this set up. Yes, I think it worked. Yes. Can you hear me well, everyone? Stand here? Okay, that's good. All right, this works. Okay, good morning, everyone. Assalamu alaikum. Hello to everyone online. First of all, thank you very much for the invitation. It's truly an honor and a pleasure to be here with you today and have the opportunity to tell you a little bit about our work and about, of course, the very exciting project that we've collaborated on with the university, with Drs. Muhammad and Dr. Effat. So thank you again for the really invitation. And I want to thank Dr. Muhammad for the very nice introduction, because you made my job a lot easier. I hope this is, I'm going to try, how much time do I have, Dr. Effat?
1 hour.
Yeah, that's fine. No, I don't want to go extra. 50 minutes is fine. Yeah, so I hope this would be more of a kind of a conversation really between us. Please feel free at any point to stop me, ask a question. We'll try to make this hour as, as least painful for you as possible. Just a couple of disclosures before I get started. As Dr. Effat mentioned, I'm a principal and a proms lead at CCHO, a consultancy firm, and a member of the Eurocall group. The Eurocall group is the group that founded the EQ5D instrument, which I will talk to you a little bit about today. So I was hoping that by the end of this sort of hour, 50-minute conversation that we're going to have, to kind of talk a little bit more about what are economic evaluations and why we need them. And you've seen a really nice introduction by Dr. Muhammad about this topic. And perhaps I will probably focus a little bit more on the second part, which is the EQ5D instrument and the study that we are doing here in UAE. So just to get started and just to kind of start all of us to think about the same thing in a way, I just want to give you here 2 scenarios. We have treatment A and treatment B. Treatment A is, a patient takes 1 pill per day. It's, for whatever disease that you may want to imagine here, let's say arthritis. The pill leads to pain relief, it doesn't have any side effects, and extends life by 5 months. Treatment B, also daily, 1 pill a day, pain relief. It has a side effect of nausea, but it extends life by 10 months. Which treatment you think is better? Who thinks treatment A is better? Raise your hands. 1 person. Okay, who thinks treatment, 2 people. 3 people, okay. Who thinks treatment B is better? Okay, so now you know, of course, where this is going. I'm gonna, ask the people who said treatment A, why did you say treatment A? Can anybody just shout and answer, say something? Yeah, I mean, if they can type in the chat box, that would be really good. But someone here in the room with us, just to make it more manageable, who of the people who said A, why do you think A is better for you? Yeah, why did you think A was better? I'm just going to tell you now. Every time I ask you questions, there's going to be a follow-up question. So
I think the treatment A is better because it doesn't have any side effects. Okay. That's what we see on the screen.
Yeah. So in this case, the quality of the life that you will be in those 5 months are extended.
And the patient will be more likely to comply with the medication.
Yeah. Or I want you to think about this for yourself. Don't think about the patient. Treatment B, who thought treatment B was better? I think the majority, but who wants to tell us why you thought treatment B is better?
Actually, even though I selected treatment B, because I look for the longer term solution. However, treatment A sometimes could be better than treatment B if the patient is ages or over the 90 years old. So therefore, I think it is depend on the situation, but still I believe the treatment B because of the longer term solution.
Thank you. Yeah, so it's really, and again here, this is more, think about it, yourself. We're all, patients at some point in time. We all take medications. We are all faced with these types of decisions. But the idea here is that some people care more, or they're interested more in the quality of life and not as much in the quantity of life. And other people are more interested in the quantity of life. And of course, it's not sort of a black and white. There's sort of a trade-off. But those are 2 important elements, the quantity and the quality of life. So it's not that we just want to do interventions that extend people's lives. We also care about what kind of quality are people going to live in these extended or additional years. So here we're going to add one more element to this scenario and say that this treatment, treatment A, costs $1,000 per treatment, and treatment B costs $1,750. Which one is better now? It's difficult to decide, right? Because you're trying to take into account quantity, quality of life, and cost, and try to determine, okay, so which one, if I'm going to spend this much money, how much am I going to get out of it? So of course, there's a lot of considerations. We look at how many patients will be affected, the prevalence of the disease, the age of the patient, so many other things. But we need a formula. We need some approach that can help us take into account all of these elements: quantity, quality, and cost. And this is basically what we do in an economic evaluation. So an economic evaluation, as Dr. Muhammad introduced it a few minutes ago, is a comparative analysis of the costs and benefits of at least 2 interventions. So there has to be at least 2. We can compare 3 drugs or 4 drugs or 5, but there has to be 2. There has to be a comparator. We can compare a new drug or a new intervention to how we do care now, to usual care. But there has to be 2, benefit and cost. I'm not going to talk about cost today because that's what health economists and economists do, and it's not my area of expertise. I'm going to focus a lot on how do we measure benefit. So measurement of cost is a little bit more straightforward, but measurement of benefit in health is a little bit more kind of complex, because everything we do in healthcare, in principle, intends to give us more health. So what does that mean, more health? How do we measure that? How do we quantify that? And so this is what I spend most of my time doing. Before we get started, I just want to highlight 3 key principles that are related to this. And also Dr. Muhammad tapped into some of those. First, the scarcity of resources. The second concept is opportunity cost and value for money. So scarcity of resources, as Dr. Muhammad mentioned, we don't have unlimited resources. We're operating within certain budgets. And so I just wanted to share with you, I was actually curious to see how much does the UAE spend on healthcare. And I just used this figure from 2018 because it was right before COVID, so we're not affected by COVID, but the UAE just in 2018 alone spent 50 billion dirhams on healthcare, which is equivalent to around 13.7 billion US dollars. And this figure is, is quite high. I mean, if we look at countries with the same size in Europe, they spend probably a little more, but it is high. The point is that this figure has been increasing. And of course, we would expect that this will keep increasing. So in the first graph at the top, you see the spending per dollar per capita, and then on the bottom as a percentage of the GDP. So in 2018, it was almost 4.2% of the GDP. And then, of course, there are projections that this figure will keep increasing for the next at least 10 years and probably more. I mean, with all the developments and all the technologies and that we have available to us, we always want to acquire more technology, more treatments. We want to expand the healthcare services that we have to a lot of people. And of course, UAE is a country that's, kind of in its vision, expansion is one of the big things. The population is growing really fast. So you're going to be spending a lot more on healthcare. How much do you think UAE spends compared to other GCC countries? I'm going to tell you that it's one of the top 3, but which one do you think? Who thinks it's the highest spender on healthcare? Raise your hand. Okay, the second. The third. Okay, it's actually the first. So UAE spends the most out of all of GCC countries on healthcare per capita. So it takes into account the size of the population. And so, of course, with, going back to the concept of scarcity, the idea of scarcity of resources, we don't need to think of it as, we don't have any resources, but we have limited budgets. And these budgets, as more options we have, as the population grows, they become more and more and more limited with time. So UAE is not any different than any country in the world. Even though it's a middle income country, you still have a limited budget and you have to make decisions into how do you allocate that budget. And when you make these decisions, there's something that comes up, this concept of opportunity cost. And it's an extremely important concept when we talk about health economics. So it is opportunity cost represents the benefits of an individual or investor or business misses out or has to give away when choosing one alternative over another. So this applies, I think the most important resource that we all have, and it's the most unrenewable resource, is time. So today, you had 3 hours of your day. You could have done so many different things with these 3 hours. You could have spent it with your family. You could have went to the gym and maybe played a game of soccer with your friends. You could have went and had breakfast with someone, or you could have came to the seminar, right? And you chose, you can't do all of them. You have to choose. So you chose to come to the seminar, which we thank you for. Opportunity cost is the value of the second best option that's available. Not all of the other ones, it's just the second best option. So if you have $100 and you can spend it on a ticket to go to a concert, or you can go to the gym or spend it on a gym membership, or spend it on lunch with friends, or buy new shoes, if your next best option is gym, the value of opportunity cost is this. This is what you have to give up to do this. In healthcare, it's the same. So if we have to give up something, we can't pay for everything. We have to make a decision. If we're going to fund drug A, we have to not fund drug B. So what's the opportunity cost of not funding that? Or if we have to forego, we have to say, we're not going to be funding this intervention anymore. What's the value of that? So always what we get of a new intervention has to be more than opportunity cost. But this is another important consideration when we make decisions in healthcare. So resource allocation, Dr. Muhammad mentioned that. So that's another thing that all healthcare policymakers are faced with. And of course, it happens within different levels within the system. So again, Dr. Mohammed shared also the 4 different key types of economic evaluations. As I said, I'm not going to go into the kind of the cost side of it. The cost, as you can see, it's monetary. We can measure in terms of money, the cost of something, an intervention, a drug, anything we do in healthcare. The outcome is what varies between all of these 4 different kinds. And the 2 types, cost effectiveness analysis and cost utility analysis, are often what you see. We don't see a lot of the cost benefit is very difficult because you are putting a dollar value on a health outcome. So what would be the dollar value, for instance, on to prevent a heart attack? So that's a very difficult thing to do. So we don't see it used a lot. Cost minimization is also not used a lot because typically in healthcare, we're trying to do more, not less. And so we're often faced with, okay, if we want to do more, what we're doing, is it worth the money that we're spending? And that's the type of question that we can answer, or not directly answer, but we can get evidence from these types of studies that helps us in making these types of decisions. So here, the main difference between these 2 is how we measure the outcome. So for cost effectiveness analysis, we measure the outcome in clinical effectiveness. And for cost utility analysis, we measure it in terms of a preference or a quality. And we're going to talk about what a preference and what a quality is. So just very briefly, cost effectiveness analysis is quite simple. I'm pretty sure many of you have seen those studies. We read them all the time. So we measure the outcome in sort of maybe physiologic measures. If we are evaluating a drug for hypertension, the outcome could be an improvement in blood pressure, or if it's for diabetes, an improvement in A1C, and so on and so forth. So it's a physiologic measure. We could look maybe at mortality rates, morbidity, life expectancy. All of these could be any outcome, pretty much a clinical outcome. That's why it's called clinical effectiveness, could be assessed in this. But what we often get in terms of outcome is that we can say, okay, this is how much it costs, $1,000 per patient, for example. These are just examples, for 10% reduction in systolic blood pressure. We have versus, $1,200 per patient for 10% reduction in blood pressure. So if we're comparing 2 drugs to each other, and we want to forgo one within hypertension, we can do this type of work because I can compare, okay, well, I have 2 drugs, one costs $1,000, one costs $1,200. Obviously, I will adopt the one that costs $1,000 because I'm getting the same benefit. But when we start in healthcare, decision makers don't decide on drugs separately or interventions separately. They're looking at a wide range of clinical areas or interventions. So we have different outcomes. So how do we evaluate 10% reduction in blood pressure to 10% reduction in A1C in diabetes patients? Which one is more important? It's very difficult because you're comparing oranges to apples, right? You need the same sort of a common measure, a common metric to measure outcomes on. So can it help us say, okay, well, this costs more or this costs less? And oftentimes, the other important reason why we're going to kind of move on next and talk about qualities is it's not always the reduction in blood pressure, the main, or the clinical outcome, the main outcome of a drug or intervention. For example, in patients with cancer, a lot of drugs aim actually to lower symptom burden and improve patients' quality of life. So quality of life is the important outcome. It's not about the size of the tumor, for instance. What matters is the quality of life. There could be 2 drugs that do the exact same thing physiologically, but one with a lot less side effects that basically helps to improve patients' quality of life. So quality of life on its own could be also an important outcome. And this is why we do something called cost utility analysis, because it gives us the opportunity of measuring outcomes on the same metric, which is a quality adjusted life year. And we'll talk about what a quality adjusted life year is. And so when we get a cost, instead of saying, oh, it cost us $1,000 to improve blood pressure this much, we say we get a cost for an additional quality, a quality adjusted life year. This is how much someone gains from an intervention or a drug. And so what is a quality? The quality, it's a measure that takes into account quantity and quality of life. Simple, it's the name, quality adjusted life year. So it's a life year adjusted for the quality that people live in that life year. And again, as I mentioned, it's a unit of benefit that's common, that you can use it to compare the benefits gained from interventions within healthcare within the same patient group and across patient groups, because it's a common metric. It's not specific to a specific disease or a clinical condition. Quality calculation, it has, as we said, the quality and quantity. The quality of life is measured on a scale from 0 to 10 in a quality. So 0 means we say it's anchored at dead, and 1, it means full health. And we'll talk about how we measure that. And so this weight represents different values. So we'll get more in depth into that. So in terms of calculating QALYs, it's really a simple calculation. We basically multiply the number of years that are lived in a health state by the quality of life in that health state. And so the number of years, it's, we measure it in years. So that's simple. So the length of life is in years. And the quality weight is measured on a scale. We said it's anchored at 0, which means dead for this scale, and 1 means full health. So if someone lives for 6 years, or if a drug or intervention gives a patient additional 6 years with a full perfect health, that would be equivalent to 6 QALYs. 6 times 1 equals 6 QALYs, right? If another intervention or drug gives someone 10 years, but with a quality of life of 0.5, that's equivalent to 5 QALYs. The idea here is that 5 QALYs, so 5 quality adjusted life years, or let's say it in a different way. 10 years in this health state, which is 0.5, so half on the scale, is equivalent to 5 years with full health or full quality of life. So what we try to do is we try to adjust the amount of time by the quality of life in that time. And so that's the idea of a QALY. So for example, if we measure quality of life at different time points for a patient, and this is what it looks like without taking any treatments. And so we measure it at different times. And this is the figure of it. So here we've got same thing, time, and here we've got quality. And if we give them a treatment and we see how it improves, the difference between those two graphs, or what we call that area under the curve, is the QALYs gained from that new intervention. And so this is the QALY gain, and then we can look and say, okay, how much did it cost to get that much QALY gain? And we can compare that across interventions or drugs. And so this is kind of simply. So here you've got an example of, for instance, I think I lost the animations on this slide, but the idea is that you've got the first intervention where someone lives for 2 years on a quality of life of 0.75. 2 times 0.75 is 1.5 QALYs. Another intervention or drug, you can think of any 2 alternatives that gives a patient 6 years of life at 0.8. So this new intervention improves both length of life, so quantity, and both quality of life. And that gives you 4.8 QALYs. So when we do the difference, the gain is 3.3 QALYs. And so we look and see, okay, we measure cost and say, how much does it cost to achieve that? And we do a ratio of between the 2 different interventions. And so I talked about QALY, and it's anchored from 0 to 1, and we said that we measure that. So we said years in the QALY is easy because it's time, so it's easy to measure time. But how we measure the quality? So that Q in the QALY, which is quality. So there are measures that are developed to help us measure that Q in the QALY, and those measures are called preference-based measures. And one of the most commonly used measures for that purpose is the EQ5D. So in this equation, that quality weight would be basically a score that we get from this instrument or this measure. And then I'll introduce that. I'll show you what that looks like. And so we ask a patient to complete a questionnaire. We take their responses. We have a scoring algorithm that we apply. We get a score and we apply it there. And then we calculate a QALY for that particular patient. And we do it for all the patients in a study or in an intervention or in the health system. It depends what the application is. And so there are many countries around the world that use QALY or require or recommend the use of QALY when making decisions around reimbursement of some drugs. And my colleague, Dr. Matni, will be talking a little bit more about policy making and using EHTA in policy making. But this is just to give you an idea that this is a commonly used approach or recommended approach. So an institute like the Emirates EHTA Institute would set guidelines for those who submit requirements on what kind of evidence you should provide. So for example, NICE in the UK, which is the National Institute of Care Excellence, they manage all EHTA through NICE, and so they require all the applications to use cost utility analysis because they want to compare across different interventions and they want to use the same measure. So there's a standardization in the process. So today I wanted to introduce this study that we partnered on with Dr. Zafat and Dr. Muhammad, and of course the faculty here. We're very excited to be launching this study now. So when I mentioned the EQ5D instrument, this is a version of what the instrument looks like. This is the Arabic version for UAE. So it assesses 5 dimensions of health. القدرة على التحرك، العناية الشخصية، الأنشطة المعتادة، الألم، الإحساس بعدم الراحة، القلق والاكتئاب. So mobility, self-care, usual activities, pain, discomfort, and anxiety and depression. And within each of these 5 dimensions, there's 5 different levels of problems that someone can use to describe their health. So if I give you this questionnaire today and just ask you, tell me about how you feel about your health today using this questionnaire. So you read through it and you just tick those boxes. And I'll show you what we do after we get that. So the purpose of this study is to create a value set for this instrument that's based on the preferences of the general population in UAE, or how people view and value health. And I will go through that in detail to say, what does that mean? So this is really very proud and happy to have this fantastic team of collaborators from the university here, also our partners at Dubai Health Authority, Dr. Muhammad Farghali, Abu Dhabi Health Authority, Dr. Asma al-Manai, Dr. Sarah Dalal from the Emirates Health Economics Society, and of course other collaborators from academia. And this is a very important, this was done by design and not by coincidence, because it's very important that all the key stakeholders are involved in a process like this, because we're producing a product that will have to be implemented or used later on in cost effectiveness studies. So it's very important that everybody who will potentially be user of this value set to be actually part of designing this study and conducting it. And so first, just a quick note of why the EQ5D. The EQ5D is one of the most commonly used measures of health and quality of life around the world, for particularly the purpose of generating QALYs, for that purpose. It became very popular because there's a kind of what we call a scientific machine behind it, which is the EuroQAL group. And it's an international group of researchers. It's been doing research for over 35 years on this instrument to kind of enhance it and make it a better instrument to capture value and quality of life of people. And so given that it is the most commonly used in the world, we adopted here to use that instrument in UAE. There are a couple of other instruments that are available, but the evidence on them is not as strong. And so here I have a very quick video that I'd like you to see that will help me introduce the EQ5D to you. It doesn't work. How much time do we still have, Dr. Arfat? Okay. We'll see if it works. If it doesn't, I'll tell you what's in the video, but it's a, it's a kind of a nice introduction. Maybe you can try a different browser.
Building your business online? Go to Wix.com and get your site up and running with it.
Perfect, thank you.
Explaining the EQ5D in about 2.5 minutes. To make healthcare decisions like whether a new medical treatment really works, or if it offers good value for money, or what the impact is of a certain condition, we need to be able to measure people's health. One way we can do this is by looking at length of life and quality of life. While length of life is easy to measure, quality of life is more subjective, but we can measure it by asking patients standard questions about different aspects of their health. The EQ5D is a questionnaire that's been used worldwide. It's short, simple, and is one of the world's most popular measures of health outcomes. It was developed by the UAE Group, an international network of researchers. The questionnaire is made available by the UAE Research Foundation, a registered charity in the Netherlands. The EQ5D measures 5 dimensions of health: mobility, self-care, usual activities, pain and discomfort, and anxiety and depression. Patients tick boxes to show how they're feeling in each of these dimensions. They also rate their overall health using a visual analog scale that looks much like a thermometer. All this gives us a description of a person's state of health. This description is then converted into numbers, which can be used to inform healthcare decisions. The EQ5D is available in more than 200 languages. Its flexibility allows people to complete it with paper and pen, digitally, over the phone, in face-to-face interviews, or through caregivers. And the EQ5D is evolving. The original gives people 3 response levels for each dimension. The newer EQ5D5L offers 5 levels to pick up more subtle differences in health. There's also a child-friendly version, the EQ5DY. Because it's generic, the EQ5D is versatile enough to compare health across different types of patients, diseases, and treatments. Extensive research shows that it's a robust, reliable, and responsive way of measuring health in a wide range of conditions and populations. And the EQ5D simplicity makes it easy to use in routine measurements, health surveys, and clinical trials. The EQ5D, helping the world make better health decisions.
Can you go back to the slides, please? Thank you. Thank you. I'm just curious if any of you are familiar with the EQ5D instrument or have used it before, just by a show of hands. Okay, briefly, okay. So as you saw in the short video introducing the instrument, there are 2 versions of the instrument. The 3L version, so 3 level, which means there are 3 levels for each dimension. That's basically what it is. This was the original version of the instrument, and this was in 2000. So this was developed in the 80s. In 2012, they expanded that descriptive system and developed the 5-level version of the EQ5D, which explains a lot more health states. So here we say there's 243 health states. So the idea here, if you have 5 dimensions and 3 levels, 5 to the power of 3, you can describe 243. In the 5L, you can describe 3,125 distinct health states. We'll get more a little bit into what we mean by health states. So, of course, as the video told you, there's so many different languages and language versions of this instrument. And so the 5-level version is what we will be using here in the Emirates. The EQ-VAS, or the visual analog scale, is another, as you saw also in the video, is one of the elements or the components of the EQ5D instrument. It's a very basic question. It just basically asks someone to tell us how they feel about their own health from 0 to 100. The focus will be on those 5 questions, though, for the rest of the talk. And so I mentioned health states. So what do we mean by a health state? And this concept of health states, or the term descriptive system, when I showed you the questions, typically in a questionnaire, I'm just going to see if I can go back. Yeah, so typically in a questionnaire, any health survey, if you've seen the WHO quality of life questionnaire, or if there is an activity questionnaire, any kind of questionnaire, we call these kind of headings here questions, and we call these response options. And that's typically in instruments that we call profile instruments. In preference-based measures, we call this dimension, and we call these levels. And this is not only unique to the EQ5D. There's another instrument called the SF6D. There's another instrument called the HUI. So we call these, so when I say dimension, I'm referring to mobility, self-care, visual activities. When I say level, I'm referring to those sort of response options under each dimension. And so when we talk about a health state in in also preference-based measures. And here it's the case of the EQ5D. When we say level 1, that indicates no problems in that dimension, level 2, mild, slight problems, level 3, and so on. And always in preference-based measures, and this is again not unique to EQ5D, we start with the first dimension that's listed in the questionnaire. So if I tell you this is the health state 21134, 2 means slight problems in mobility, because mobility is the first dimension in the instrument. 1 is no problems in self-care. 1 is no problems in usual activities. 3, moderate pain and discomfort. And 4 is severe anxiety and depression. And so this is kind of, it's a really more of a 5-digit code describing the health state. And so when someone answers that questionnaire, we create this code, and then we have to generate a score for this health state. So obviously 11111 is the best health state that you can describe with this instrument, and 55555 is the worst. And so if we give this questionnaire to someone and they complete it like this, those are the boxes that they tick, we create a health state for them. It's 21134. And if you remember in that video, it says someone completes it and then it shows you, oh, and then we create a score from this, but it doesn't say, how do we create that score? Where does that score come from? What does it really represent? And so we have scoring algorithms that we create to score this instrument. And the details of the scoring algorithm are not really important. I just want to show you an example of, it's basically an equation. This is a regression model, 1 minus blah, blah, blah. Very simple mathematical equation. And you get a score of 0.58. So the value of this health state, 21134, is 0.58, but it's 0.58 based on the Canadian scoring algorithm. So what does that mean? If I take the same health state and I apply a different scoring algorithm, and this is the one that was developed for Egypt, also for the 5-level version, I get a score of 0.49. So it's different. So where does this score come from? And so, of course, it varies for the different health states, the lower end and the higher end. And this has been done in over 50 countries around the world. So every country has its own health state or values. These values, they represent how the general population values health. So if I complete the instrument here and you want to, and I tell you my health state is 21134, you will go and look, how does the UAE population values that health state? And that would be my score. So how do we get that? How do we know how people value health? And so this is basically the study that we are doing here. We're doing a study so this is just a kind of a recap. You know, you get someone to complete the instrument, you get a health state. Now we go to the general population and we generate a value set. We ask them questions about these health states. So as you remember, for the 5-level version, it describes 3,125 distinct health states. So our job now is to generate values for all of these 3,125 health states. So when someone here, if you want to do a cost utility analysis in UAE, and you want to say, I used local preferences, you use that value set to score your instrument instead of using a value set from the UK or Egypt or Canada or whatever. Because as you saw, values differ. The way people view health is different. And so this is where we get that score, and then we use it back in the quali, right? So this is, it goes into the Q in the quali. So just to get that Q in the quali that goes into the economic evaluation, we have to go through this sort of a societal exercise in a way to understand the values of the population. So the way we're doing this study here, and this is of course following the protocol that was developed by the Euroqual group, and which is also implemented in all countries around the world. Of course, we make some modifications to make it fit here, but the methodology behind it, it's the same. So we will recruit a sample, a representative sample of the UAE population, and it has to be 1,000, so we can do the analysis. That's a minimum of 1,000. we will administer what we call health valuation exercises. So those are the exercises that we sit with people and we ask them questions to see how they value health. So we can actually get those numbers that we were talking about. And I'll show you examples of which ones we are actually planning to use in this study. And then we collect all of that data. We, of course, ask some more demographic questions. So here we have questions about age, income, marital status. We ask people if they have any chronic conditions, experiences with health, and so on and so forth. And then we create a value set. And so this value set becomes the set that represents preferences of the general population for the EQ5D instrument. And it's a product that could be used for many, many years by others who are doing cost utility analysis. We are also planning in this study to do some validity work to look at the validity of the instrument in UAE, as well as a sort of secondary objective of the study. And so I told you, how do we ask, how do we assess how people value health? There are two main techniques that we use. And this is actually the most important one. So what we do, this is called time trade-off. And so the idea is we ask people, we give people a health state, and we ask them, how much are you willing to trade off to avoid being in this health state? What we're trying to get at is how much value do you put for this? If we directly ask people, put a value for this health state on a scale from 0 to 1, it's very difficult because when you don't have an alternative, this is the basic principle in value, you realize what the value of something is. You need to know what's the alternative. So the task starts like this. You present someone with these two options. The first option is what we call life A, which is the bar, the green bar, and life B, which is, so the green bar is 10 years in full health, and life B is 10 years in this health state. So it's moderate problems in walking about, unable to wash or dress myself, unable to do my usual activities, extreme pain or discomfort, severely anxious or depressed. So we ask the participant, imagine yourself living in this health state for the next 10 years. How much would you trade off? And then we go through this iterative process. Do you want life A or life B? And so that bar starts changing the 10. It goes from 10 to 8 to 9 to 8 to 7 and so on. It could also go below 0. And it will stop at some point. Like for instance, it stops here. Someone says, you know what? 5 years in full health is equivalent to this health state for me. I don't think there's a difference now. And so this is what we call the point of indifference, that these people are not, there's no difference for them. They value these almost the same. That's sort of about the same. And this is how we calculate the value of the health state. We just take that amount that's left on the 10 years, so it's 0.5. So the value of this health state on that scale, 0 to 1, is 0.5. And so what we do is we ask these questions to the whole population. And of course, the value of this health state won't be based on one individual. It will be based on the average. So the value of this in the health state will represent, on average, how the general population views health. And so if you think about, okay, why are we doing this? Why do we go ask the general population? And so, and then to score someone's health. So the idea is you want to kind of engage and involve people in somehow in an indirect way. And people, by people, I mean taxpayers, in how you make decisions, because budgets come from taxpayers. And so, primarily, I guess. And so it's an indirect way to really engage people and have their preferences, what matters to them, incorporated into how we do these value measurements and assessments. And so, of course, this is the other, it's called discrete choice experiment. The other technique is much simpler. We just give 2 health states and we ask them which one you prefer. And this is just, we use those 2 techniques and when we do the analysis, we anchor one on the other just for analytical work. But the first one is really the most important technique. That's what we base the value set on. And so this is what we are planning to do here in this study. We've already recruited 12 interviewers to help us with the data collection. We spent the last 2 days training the interviewers on how to do this task, how to use it. we will be doing the data collection in both Arabic and in English. So hoping that this will capture the vast majority of how people can complete it. These are just some kind of the key outputs that we are hoping to get out of this study. Of course, the value set is the main thing, some validation work. We're also planning to generate population norms. So whenever you do a study with EQ5D, you can say, well, this is how it compares to the general population. And of course, there will be, most importantly and most relevant for our discussion today, is that we view this study as sort of a building block in setting up the infrastructure that Dr. Mohammed mentioned around HTA. So in order to do proper HTA, you're going to ask people to do economic evaluations. And to do economic evaluations properly, you need the tools, the local tools. And this is how we are trying to help to build this infrastructure locally. And so, of course, as I mentioned, there are many studies, many similar value sets around the world. I just mentioned the countries here in the region that I've worked with to help develop these value sets, although the one in Lebanon is a bit on hold now. And this is just a final note about the EQ5D instrument. So we are using it in this application or for this purpose, but the EQ5D instrument can be used in many other, as a health outcome measure in many other applications. Actually, we use it a lot in my work. I come from population health background, and so we use it a lot in population health assessment and surveys as an outcome measure. Within the healthcare system, there's a movement around the world to assess outcomes of care from the perspectives of patients. So in the UK, a lot of this work started, and we have a lot of initiatives and programs in Canada. There's also programs in Sweden, and there's some international initiatives that are headed by the OECD to incorporate these types of measures, and there's the EQ5D is used into how we evaluate outcomes within the healthcare. And so similar work will actually be happening here in UAE as well. We're working with Dubai Health Authority on developing something very similar in Dubai for now. And so, of course, there's multiple applications for this instrument. So it would be really important to understand how it functions here, how it works, what's the validity, and have, of course, local value sets for it. So this is all I had for the day. I think I stayed within the time. Thank you very much for listening, and I'd be happy to answer any questions.
Take some questions. I think we have some time before we go to break.
Yes, please.
There's a question from someone raised his hand online. Should
Yes.
we start with the online?
Well, however you prefer. I'm fine.
So Mohammed Al-Breiki, you can just open your mic and speak.
Hello, can you hear me? Thank you so much for the presentation. I have two questions. I understand that one target of these evaluations is to enhance our understanding of the cost effectiveness of a healthcare technology and to measure the outcome of these interventions and to make the right decision in terms of human health. But isn't this like bias toward human health or a human-centered approach precludes the real cost benefits from other approaches that show the complete picture of how human health is linked to other interventions in the animal or environmental sector? Like, isn't a One Health approach for economic analysis a better option?
A One Health approach. Can you just elaborate on that? Is there a specific? I'm not sure what you mean by One Health approach. Yeah.
So if it's an approach that takes interdisciplinary and integrated like approach to link human and animal and environmental health to optimize the health in general.
I mean, of course, as you say, in terms of being more holistic or looking at the system overall, conceptually and theoretically is always probably the best way to go. Like when we talk about health, if someone has, a patient has cancer, it impacts their job, it impacts their family, it impacts maybe they have to move and live somewhere else because they need to be close to a cancer treatment center. So of course there are, implications that are beyond health. But when we talk about resource allocation within health, we're kind of trying to create tools that will help decision makers within the discipline, within the field, because within health, there is a budget that's allocated to health. So how do you make decisions in order to allocate this budget in a way where you get the most out of every dollar that you spend? That's sort of the idea. And so when I think the governments will have to start this so we can follow. When governments and sort of, the education field starts working with the sharing budgets with the health field, then we can probably perhaps think of a more kind of a holistic approach. I'm pretty sure this is being done, but when it comes to these specific tools, measuring these things are very difficult. We didn't go into the details of measuring outcomes. We just wanted to focus on utility because we only have the hour. But in the context of economic evaluation, you can do it from a healthcare system perspective, or you can do it from a societal perspective. So in either case, when you're measuring benefits or you're measuring outcomes, or costs, you can measure them from both perspectives. So in some studies, we measure how much does it cost someone to go to a hospital to take a drug, which is not a cost that's incurred by the healthcare system, but we measure that. So you can take different perspectives, but the decision maker is only interested in the healthcare system perspective because that's the budget that they can actually manage and control. And so, of course, it's not a yes or no or a black and white. It's just a perspective depending on where you are, how the government functions, what kind of decisions need to be made, and so on.
His question also regarding the underrepresented groups.
So just regarding this tool, for example, if there is an intervention to prevent a zoonosis in an animal population, a zoonotic disease that can cause, damage to human health, will it like measure the benefit from this intervention in the animal sector, for example? Can it like measure the benefit of this intervention to the human population?
But not using the tools that we just talked about today. This is specifically in terms of how we measure impact of any intervention on human health in terms of health outcomes as experienced by humans. We haven't created an EQ5D instrument to measure outcomes from perspective of animals, but I have to say, I don't know how this is done in other sectors, or if you are actually going to measure like from the One Health approach, taking into account animal and environmental impact. This is not my area, so I would say I can't speak to it really, but I can speak to the human health approach.
Maybe
okay.
future something about climate change.
Yeah.
And
just one question.
Yeah. Can we have to give chance to others?
Can we give a chance to those who are in the room, please? I think I'll start with Dr. Basima because she raised her hand first.
Thank you very much for a very interesting session. My question is really about, I mean, it's great. We all understand the burden of disease. And when we talk about burden, we always forget that it's not just the physical, it's everything else, including quality of life. And I'm really excited that you're actually starting or validating this tool here among an Arabic speaking population or the UAE. My concern is I noticed that there were different algorithms to get that score for different countries, Egypt, and I can't remember what the other country was that you used. But given that we have such a large expat population here in the UAE and different perceptions based on where people are coming from, who are you using to validate, or what population is going to represent the population here in the UAE?
This was the hardest, I'm glad you asked this question because I didn't have enough slides to put that in, but so this is one of probably the most controversial things that we had to decide on because we often in other countries, we don't face this challenge to the degree that it is here. And the other important thing, it's not just the number of other nationalities, but it's that it's a highly transient population. So people come here, stay for a few years and then leave. And so we wanted to kind of describe what would best represent who is the general population in UAE, particularly when you're creating something like this that will be used for years to come. So we're not going to do a value set perhaps until maybe another decade or two. And so the way we thought about it is, so we have a multi-stage quota sampling approach. First, most importantly, both nationals and expatriates will have to be represented. And so the breakdown for now is 15%, 85%. So in our sample, in our sampling approach, we aim to recruit a sample that will be 15%, 85 split. Of course, you may end up with, 14, 86, but we are aiming for that in our approach. The second layer is within the Emirates. So we looked at the distribution of the population across the 7 Emirates. And then we said, okay, based on the size of the population in each of these Emirates, we're going to recruit a certain number of people. So we were recruiting across all 7 Emirates in the percentages that represents the population overall. And then within that, we are looking at age and gender quotas. So we break that down into those quotas. So we have multi kind of a layer sampling approach. Of course, there are other things. I mean, if we, and this is something we were discussing with the interviewers and how we're going to recruit and where we're going to recruit. You can, with what I just described so far, go here on your campus and recruit all of these people. But that is not representative of the UAE population. So the other layer or the other consideration that we take into account is where we recruit, how we recruit, because you want to make sure that you engage people who in lower paying jobs, people who are not. So make sure that you represent all the sectors and all the groups in the population as much as possible. Some groups are going to be a little bit harder than others. If you have males in 25 to 35, if they are in lower paying jobs, they're probably doing 14-hour shift a day and they go home to their family. They're not going to give you 45 minutes or half an hour, which is what it takes to do this. So we will evaluate, and our plan is to every 100 participants we recruit, we're evaluating our sample and we're kind of directing where the recruitment should go, who is not represented so far. We should focus more on this, on that. So in terms of males, females, Emirate, expatriate, and local, we have that sort of covered in a way.
Maybe to add to this, that we chose the 10 years,
yes.
being in this country for 10 years.
Yeah, so for the expatriates, the inclusion criteria is to have lived in UAE for at least 10 years. So people actually are here, they have interacted with this system, the health system, the environment, because we showed an example of how you do this health state. If I tell you, how much would you give up, how many years would you give up to avoid living in a wheelchair? You are going to think about, where can I go in a wheelchair? And that depends on where you live or, the surroundings. So we kind of took that into account in that way. And it was honestly kind of an arbitrarily decided number because there is no guideline anywhere else on how do you choose that number. Thank you.
We have so many questions, but
do you wanna, I'm fine.
Yeah, what we want to go. Shall we leave it?
We can take 2 more or
2 more.
Yeah.
So we'll go with Dr. Balash, I think.
I'm fine. It's Dr. Afat who
no, just decides. To give you some time to rest and to take some refreshments.
Sure.
Thank you.
Yes.
Thank you, Dr. Rifat. It's Balaj Adam, IPH. I have 2 questions. One, the first one will be a bit more technical. The other one is more general. I have a quite long-standing background in doing health impact assessments, and that's where my questions are coming from, actually. I understand that especially the European Union and economic evaluation favor QALYs. And this tool and your study, what you are describing is about the quality weights, how to determine quality weights. Well, in health impact assessments, we use DOLIs, and DOLIs use disability weights.
Yes.
The approach of establishing one and the other have many similarities, like trade-off methods and things like that. So my question would be, are there any major differences in between these 2 weights? And the second one is that as we know, one of the biggest and most well-established public health project is the Global Burden of Disease Studies. and they use dollies also. And in establishing the disability weights for these huge global burden of disease studies, they argue that these disability weights should be usable around the world, internationally comparable, so using the same weights everywhere in the estimations. While you are designing and measuring quality weights based on populations one by one, because of course these weights can be different by cultural background and also environmental, societal, economic background. So what is the advantage and the disadvantage of using internationally comparable and not comparable weights?
Thank you, really fantastic questions. So DALYs, I had a really nice slide, I should have left it, about getting from the DALYs to the QALYs. So most importantly, this is not necessarily, this approach is not to replace how we do things, it's to enhance how we do things. So we still look at mortality, we still look at morbidity, we still look at disability, we still look at functional, a lot of things. And so this is another layer of how we measure outcomes in a way from people's perspective. And so the DALYs, disability adjusted life years, it's kind of the opposite of a QALY. So in a QALY, you adjust for the quality of life in those years. In this DALYs, disability adjusted life years, adjust for disability. But measuring disability does not come from people themselves. You look at parameters in the population and you estimate the disability weights. And this is how you can calculate QALYs. So there's a very different approach in how you assess this or this. But on your second point, it's very, this is why I wanted to specifically mention we follow the same protocol. So yes, disability weights vary from country to country, right? So if you're generating DALYs in UAE, they will be different from DALYs in other country. So it's the method of doing it is the same, but the result, the numbers are different. Right? It's the exact same approach. It's the exact same idea. So we use the exact same method. It's the exact same protocol. Even the last 2 days when we trained the interviewers, there's only a group of us at the IRQA who actually can do this training. It's the exact same training. It's standardized across the whole world in terms of even how we train people to do this. It's the exact same platform that we use for data collection. It's the exact same methodology, analytical approach. So the difference is that we see between countries, as I showed you in that example, there are true differences in values and not because of how the methodology was done. So it's not a measurement error in here, in your biases and how we collected the data and so on. So that value set is intended to represent how values of this country are. And of course they are different. They have to be different. I mean, mostly, even in the closest countries, things are different. So people think about health in different ways. So with the EURQUAL, first of all, the instrument itself is, there is this sort of validation work when you take it from country to another in terms of language and so on. And then in terms of the value set generation, there's a standardized protocol, which is also published on how you do that. And sort of, and also a step-by-step quality assessment to ensure that you are getting, so we have like certain quality criteria that we follow as we collect the data to ensure the data is collected with the least amount of error and so on and so forth. So there's like a big data monitoring phase as well. And this is again done across the world in every study that we do. So what we basically say is that to a certain extent, there's always error, right? There's always measurement error. But we try to minimize that and minimize the bias as much as possible in the way we do things. And it's sort of how much error we accept. So we follow the protocol exactly the same. And in theory, it should be comparable. In the context of economic evaluations, it doesn't matter much unless you're probably doing an international clinical trial, multinational, different countries. But for decision making, it's often local. So it's localized, and that comparison doesn't matter much. In population health assessments, of course, that's important. We actually have a large international project. We have 12 countries already included, looking at health outcomes in the population using different measures. One of them is the EQ5D. And so be happy to tell you more about that maybe during the break, if that's your area of interest.
Can we leave the question? Sorry, I know Dr.
Sorry, I
Abed-
talk too much too. You have to stop me.
Yeah. We have a plenary session after Dr. Mirna's session. Can we leave the questions to that plenary sessions, or Professor Abed
Mine is a quick one. It's a more generic question on the EQ5D, which is about its validity. The questionnaire is done based on the European population, and the Europeans have different health systems, right? So to transfer that information to non-European countries, for example, in the Middle East and Pakistan, you mentioned, you know, and India, etc. And health is related with your perceptions based on the culture and the health systems, and they're all different. So how you can validate that questionnaire on the health statement to other populations which have different cultures and different health systems?
Can I answer this?
Yes, please. Oh, that would be wonderful.
Because we've done this feasibility study in 2015 here in the UAE.
Yes.
So
and
we
Dr.
tried.
Afat was leading it.
And I was part of the group who was doing
Yes.
this. And in 2015, we've done this study on a 200 participants from the UAE population nationals. And we were trying to see if it's feasible. And we got 2 published papers. So I invite you to read these papers on this. And we have seen that it's feasible. And that's why I think it was delayed to set this study again. But thanks to Dr. Fatma, Dr. Mirna, and the group.
But a sample of 100 people is not enough, you know. So if you have to roll out to the whole population, then I think you need to.
I'll leave it to you.
Yes. Oh, yes. Well, validity and reliability are very interesting topics, because we never say actually that an instrument is valid or reliable. It's only valid or reliable. It's the measurement that's valid or reliable. So if I have a sample of 1,000 people, which what we will have in this study, or even 3,000, and I look at validity and reliability of an instrument, and I have evidence of that, if I administer it again, it doesn't mean it will be valid and reliable. So it's a very sample-dependent characteristic. Although we often use these terms, we say the instrument is valid and reliable, but it's not the instrument. It's actually the data that you get from the instrument. So part of the exercise that we will be doing here, because we are using this instrument with these 1,000 people, is we are going to look at construct validity. We're comparing it. We're also administering another measure, the WHO Quality of Life Questionnaire, which is a quality of life measure. And so we want to see how those 2 instruments compare, what aspects of life they capture. Quality of life, the WHO Quality of Life is a broader, it's considered a quality of life measure. It's not just health related. So we want to see how the EQ5D compares to that. How much does it capture in terms of health compared to the other instruments? So this will give us more confidence in this particular sample. So we're not just basing it on the thousands of studies that were done somewhere else, but actually on a local sample that will actually be giving us the value set. So that's when I showed the different objectives of the study. That's one of our key things.
I mean, there are certain 3 dimensions: mobility, self-care, and there's expression of anxiety and depression. That's all culturally based. And people in this area, they have different views on that.
Yes. Yes, Professor, it is intended, these measures are intended to be objective. They're intended to be subjective. They're intended to be based on what the individual thinks, because it is about their own health. So if you ask me about, you know, what would a moderate pain for me be, it would be different from you. But it doesn't matter, because it's about what I think for me. It is purported by people. So it is intended for it to be that. But of course, there's a lot of work on the measurement process.
Let's stop it here. Thank you very much. I think this is a long discussion and has lots of areas to touch on. Let's take, we were supposed to come back at 12, but let's take 20 minutes. Please have some refreshments, and we'll come back at 12:20. Yes, so we can, we don't delay you. I know some of you are from outside the line, so we'll try to finish as early as possible. Thank you so much. And thank you very much, Dr. Fatma, very much. Thank you to Dr. Sadiq, and for the rhyming between both presentations. Excellent. Thank you. So thank you very much for coming back to this session. And I would like to introduce Dr. Mirna Matni, who also have joined us today to inform us more about EHTA or HTA assessment. Dr. Mirna is a director of health policy and payer insights at the center CCHO, which is the Center of Health Economics and Outcome Research, which is located in Dubai and Beirut. Dr. Matni has more than 14 years of experience in the public sector. She worked in the Ministry of Public Health in Lebanon, I assume, the Drug Distribution Center for Chronic and Life-Saving Drugs as the head of the committee in charge of receiving those medication. Then she joined the National Social Security Fund as drug committee member, rapporteur, decision maker in registration and reimbursement of drugs in all therapeutic areas, where she introduced the concept of health technology assessment. She's a lecturer at the Lebanese University, Faculty of Sciences, ESA Business School, MEMS, Sagesse University, Faculty of Public Health, and Saint Joseph University, also in Lebanon, as for the topics related to health technology assessment, managed entry agreements, health economics, and health system. So the floor is yours, and thank you very much for being here today. If you want to, do you have a pocket, or do you prefer to hold this?
Oh, thank you. Thank you, Dr. Affat, for the presentation. And I'm really happy to be here with you today. Congratulations for the Health Technology Assessment Unit at the university. Thank you for inviting me. And I guess that I have 40 minutes. And in those 40 minutes, I will be talking about health technology assessment from a different perspective, from the perspective of government, healthcare, decision makers, budget holders, and payers. Why do we need health technology assessment in our region? Is it really impactful? Does it really serve and address challenges of our payers in the region? So basically, I will go through a small introduction. I'm happy that Dr. Muhammad did a great work while introducing what is health technology assessment, what is the real process, what are key principles. I will go over them in a qualitative manner where we can discuss several points related to HTA process, and then tackle the part of HTA around the world. So you know that HTA is not something which is very new. It's old. It started long time ago because it was needed. It's not because it's really this trendy science, because healthcare decision makers, they really needed to have a tool helping them to decide about the reimbursement of products and new health technologies. After that, we will talk a little bit about the MENA region and open the floor for question, discussion, any question that you have. So we have also to say hi to the virtual team with us. And starting with maybe a scenario that I was confronted to for more than 10 years is like, you have always to make choices. You have to put yourself in the shoes of the budget holder. So you are the budget holder, you are the payers, you have to decide, so what are the challenges you are really facing? And if you look at this example, you can see that you have to make choice between two drugs, very promising drugs, new drugs coming to the market. You have a limited budget, which is 100,000 or whatever. You have a specific population, and then you have two drugs. What drug is better? If you just take a look for a few seconds, and who can tell me what is his best choice? Drug A, which is less costly than drug B, with a prolonging life of 1 year, and B prolonging life by 1.5 years. And with drug A, you can treat more patients, definitely, because the price is less. And if we look more, the drug A is IV, drug B is more oral. So what could be your choice? Why drug A? So you did you did a small exercise of analysis, and for you see that you will be having more value with drug A than drug B. So are you convinced with drug A? Yes.
No, I think that because it looks like that the way that drug need to be administered through by intravenous injections. So the patient may need to come to the hospital or the healthcare settings. While this drug B is more, a patient might be more likely compliant. It's oral medication, although it's expensive, but we can prolong life as like a trade-off thing.
Okay, so Professor is more introducing the patient maybe preference of taking the oral rather than the IV, maybe taking into consideration the cost related to the IV. And basically, we're just looking at drug A, which is costing us $2,000, but maybe it's more because it will really have an impact of hospitalization. Maybe we will pay more. So I guess that we totally agree that we cannot directly decide what is the best technology to be adopted, whether it's A or it is B. How can we decide? So basically, health technology assessment is the answer while providing several evidence-based tools to tell us which might be better. So there is no right or a wrong answer, but we have to rely on certain tools in health technology assessment. So here we come with the pressure that all healthcare systems are facing all over the world. It's not really related to low, middle, or high income countries. All healthcare sectors, all government, and here you can see at the UAE level also, they are moving into more value-based decision-making or relating some tools of health technology assessment. Why? Because all healthcare systems are under pressure. They have to make choices, but the question is not whether they have to make choices, but how those choices are made. We cannot reimburse everything which is clinically effective. And we can, if we just jump into an overview and a simulation extrapolation of the pipeline coming to the market. So basically by 2030, we will be having more than 80 to 100 indications with very costly products, so which are gene therapies, very costly ones. So how are we going to assess? And here we can relate, I guess, why are healthcare systems under pressure? So we have, can you tell me like just one of the causes why healthcare systems are under pressure, even if they are considered like high income countries? Yes?
The cost of these new drugs is
Exactly.
expensive.
So we have more health technologies that we had in the past, right? And second,
the pressure from the drug companies and also from the public as well, because if it's just advertised in the social media, for example, more people will be asking for it. So
okay, so we have the pressure. It's exactly, we are under pressure because patients want the universal health coverage. They want the best treatment, the physician pressure. And what else also? Maybe we include the demographic increase because we see that we have a high number of one demographically. And then the patients are living more because we have promising technologies there. So if we just look at the global oncology therapeutic sales, it's expected to be like 250 billion by 2024. This is to say that we are all aligned that policies and practices has to change. So we cannot rely on the same way we used to assess drugs. So 10 years ago, we used to assess the new technologies in a different way. We were relying on what, basically? Whenever we decision makers, budget holders, we want to decide about reimbursement. So basically, long time ago, we were relying only on the medical aspect. So basically, is it safe? It is efficacious? The outcomes are good. So there were not any other domain which was included into the analysis. Now, what are the challenges of the payers? So I want you really to look at this slide because it's really very important. It will answer all the questions that we have on health technology assessment. Payers are confronted to challenges related to affordability. So they don't have money to pay for everything, right? So this is one, affordability issues. Second, if they can afford to pay for this new health technologies, how can they be sure that this is the best value for money? And on another hand, how they can be sure that their patients are responding in the best way possible? How can they ensure that this is the best treatment option, which is really the best between other options, like my colleague said about opportunity cost. So if we want to answer the first question for the payers, affordability. So what do we address in terms of economic evaluation with Dr. Muhammad? So I'm a payer, I'm concerned about affordability, and this is a challenge I am facing. So what is the research part giving me in order to tell me that this product is affordable to you or it is not? What is this tool? Do you know? What is the tool in economic evaluation that is addressing the affordability for the payer? So basically, the answer is in health economics side, it's the budget impact analysis. So budget impact analysis will address affordability. When we want to address the best value for money, what is the tool in health economics that is used? It's cost effectiveness analysis. So I'm just correlating the research in the domain of health economics to the challenges payers are facing. If we want to address patients and whether they are really benefiting from the new treatments, so here comes exactly what Dr. Fatima was mentioning, patient-reported outcome measurements, telling the healthcare or the healthcare decision maker that this technology is really addressing a concern that you have. If we are not addressing concerns important to the payers, so we're not saying anything, and the research will fly in a domain, and then decision making is flying in another side. And this is really the meaning of it. If we just do publication and research, and this is not correlated to the decision maker or the policy of the country, it's not a winning point for all. On the other side, what is the best alternative? So how can I know that this is the best option? And here comes the comparative effectiveness research. It's a science also which is used into health technology assessment in order to address challenges of HTA. So I hope this slide is really a little bit summarizing why HTA is important for payers. Long time ago, starting like in the 70s, 80s, till now, and the science is booming and being more enhanced. So for you, if I want to ask a question for one of you, telling you that I have a new product for the colon cancer for stage 3, and what for you will make this product I am showing or I am presenting valuable? It is because I'm addressing better clinical efficacy, or because my product is safer, or because it's more convenient for the patient? How can you address those values? Can anyone has an answer? Okay, so Dr. Fatima said all together. I will complement what you are saying to say that it really depends on the perspective. If I am a patient, then convenience is important to me. If I'm a payer, then I will pick value for money and affordability issues. I'm a physician. So basically, the highest value for me would be tackling more the clinical efficacy. So all will depend on the perspective. And one of the questions, I guess, before on the EQ5D and the health related or environmental related, it will depend on the perspective. If I'm really looking at correlating what I am paying to the health for me, the most important value for me as a payer, this is very important. So I won't start by doing a cost utility analysis if it's not requested within a dossier presented to the government. So basically we have to join effort and really correlate the research domain to the policy domain. Now, we are all aligned that innovation is there, so we have to create more innovative solutions. And in a summary, before really digging more into HTA, we can say that HTA is important because it will answer a very important question. How and where shall we spend our healthcare budget? And here comes health technology assessment. I will go over it very briefly because it was addressed by Dr. Muhammad in the morning. So what is HTA? The HTA process and key principle of the HTA. I want to have an HTA body in Abu Dhabi, or I want to have an HTA body in Dubai. So how, or at a national level. Or what is better, to have it at a national level or to have it like in each and every Emirates? So those are very important questions. I cannot like start by establishing my own HTA without addressing some key considerations which are very important. What is the HTA process? What are the steps I will include in my methodology, and what are the key principles? So basically, who can define HTA, to see if Dr. Muhammad really addressed it in a good way? Okay, so health technology assessment. Okay. Yeah, sure. So I pick. Okay, so basically I won't be that strict. So just to say, so basically health technology assessment is a science, right? It's a science one. Second, it includes a multidisciplinary aspect. So in this multidisciplinary aspect, so we can see that we are all dependent on each other. So we need several areas of expertise. And as I said before, health technology assessment, we used to address technologies and assess new health technologies based on the medical aspect of the new technology. And now we are including the economic aspect, where we have all the health economics research. So here in the HTA, economic considerations are there, clinical considerations are there, social, ethical, and legal. So that's why HTA is important. And do you think that HTA is like one size fits all for all the countries, or it's really context specific? Why it's context specific? Excellent. And what might be really very, very different between the ethical, yes, the social, yes, and what else? Quality of life, yeah, in some cases, but it's not really the major for healthcare decision makers. Sometimes they might rely on other health outcomes, for example, but which is not something which is valid. But they might do it in the region. We did it several times. But what is really what is really different when we do this sort of economic evaluation? The budget, so the affordability, yes, and second, something which is really very much different. If I say that this product is cost effective in UK, it's not cost effective in UAE, right? Or it is? Okay, sorry?
The funding of
the disease burden. Okay, so the disease burden is a broad word. It's very important, but it's like some parameters in the disease burden, which might be different. Prevalence, okay, so it's related to the budget. The patient related to the part of health outcomes, but the clinical might be transferred, right? So if this product is good, the RCTs, I can take them and include them in my in my decision or formulary. What might change a lot are the costs that you are using in the economic evaluation: cost of hospitalization, cost of the physician's visit, cost of the resource utilization, some indirect costs. Costs are not the same. That's why when the MENA region started to say that, this product is having a positive report from NICE, which is the HTA body in UK, then they said, okay, we have to include it in our formulary. And this is wrong, because costs are different. So it might be cost effective there and not here, and vice versa. It might not be cost effective in other countries, but it is cost effective based on the context of UAE. Yes. What is? Okay, excellent. So what is the difference between cost effectiveness and budget impact analysis? Budget impact will address the impact on the budget. So if you have a new product presented to me, what is this impact? So I have to pay more, like $2,000 per month, because I'm introducing your new technology. So you are addressing my challenges related to the affordability. Can I pay $2,000 per month or not? If the answer is yes, I can pay $2,000 per month, then my second question would be, okay, it's affordable, but what if it's not giving me the best value for the money I am spending? So the value related aspect is related to the cost effectiveness analysis. So the two are different based on the message at the end. So, and this is very interesting because there is some confusion in our world between those economic evaluation tools. Each and every tool will give and address a different concern for the payers or the budget holders or whatever. So is it clearer now?
If I may add just one quick note on,
okay.
on what you, if I may just add
yes,
one
sure.
quick note, Mirna, and it's the other way around too. So an intervention could be cost effective. So it's worth what you put in it, but you don't have money to pay for it.
Yeah.
So in terms of affordability, you don't have the budget to cover it. So it goes both ways. It's not the... Mm-hmm. Mm-hmm.
Excellent. Yeah.
Yes. Of course. Yeah. Oh, absolutely.
Sure.
That's
sure.
the point that
sure.
Mirna mentioned about if you do a study in the UK and the drug is cost effective, and then you go to Lebanon, I mean, we're broke at this point. So we're like, no, I mean, it is cost effective, but we can't afford it. So
yes. And the problem here is that in our region, because the experience I have in the region with meeting all people there is addressing really those, because we usually have the trend to copy others. So if it's really cost effective in France, but the key decision criteria are different than mine. And we're going to see them. Just start to analyze that we have some differences between two. And what was just mentioned about cost effectiveness, yes, we are usually confronted to very good products, promising ones, cost effective ones, but we cannot pay for them, and vice versa. So we can pay for them, but they are really a very bad product. So no value for money. We are paying too much versus the value we are addressing. So it's a little bit different. It will come through the session. Okay, so
can I just think
yes,
about
sure,
on
sure.
your previous slides on the ethical issues? I mean, one of the example I can think of, and certainly in the UK, there's been a lot of debate on the patients with multiple sclerosis. They do have pain, long-term pain. So how you treat or manage that pain. So the use of tetrahydrocannabinol been pushed on by different, the sectors. And the government been resistance because of the ethical issues, whether we want to make it illegal use of that drug or not.
Yeah. So this might change between culture and context. Excellent.
And
Fertility,
California,
contraception.
for example, it is available.
Yeah.
So while in the UK, for example, they're resisting to introduce that. Thank you.
Thank you so much for sharing this. What about the social part? So the ethical part, this is an example. What are the concerns of the social? So it's more addressing what we call the equity. So whenever I decide, so the decision might be for all my population and not really to select. This is the equity. And this is part of the HTA. So the considerations are economic, medical, but they are also concerned about the equity aspect of having this for all the population and sustainable, not for 1 year and then dropping out from the formulary in the other year after. Now, HTA is there, yes. Thank you for UAE University to create an HTA unit where we have the research domain feeding the challenges of decision-making domain. So here we have challenges, we have some unanswered questions, and the research will enhance this sort of HTA. Okay, so basically, what do you think that the decision of HTA would be at the end? So what are the decisions that we might have? So either it is I've done the HTA, I've run my economic evaluation, I've run my clinical evaluation, I included ethical considerations, social, legal, and then the answer might be either no, I don't want to reimburse this product, or it's not really worthy, and it's a rejection, not inclusion in a formulary, or it can be a yes, I don't have any problem, or I say yes, but it will be used in a certain eligible population, best responders. I want really to have it for a certain number of cycles because I don't believe it will work after. So all those answers are related to the HTA at the end, the HTA conclusion, the HTA report. And who is usually running HTA bodies in literature? So usually it is run through, I don't know why it is like just going. Okay, who is usually running HTA? You know some HTA bodies in the world? HTA is a new domain, right, to you?
I mean, in the UK, they've been running it for many, many years. And
UK,
more recently, it's a NICE which has taken over.
Exactly. In Europe, we have so many, we're going to see it. We have EQUIC, like you said, NICE in UK, EQUIC in Germany, PBAC. Usually it started by being included into independent universities. So it started where the research is there, we have some studies being done, and yet feeding the decision at the level of the government. So what about the HTA process? How many steps we have? We saw it with Dr. Muhammad. How many steps we have in an HTA process? Guess. We might have, okay, so basically we might have 8 or 9 major steps. So, and we're going to see the difference. We have several steps. So the first question is that, do we have to really abide by those 8 major steps? If I want to have an HTA body now, do I really have to go by step 1, step 2, 3, 4, 5? What do you think? So the answer is like, ideally, in a really very ideal, the NICE, the UK, not the Italy, for example, or Spain, you might really go through all the 8 major steps. But in several cases, we can see that they are omitted in several jurisdictions. So sometimes we can just select our topic to appraise, select the decision problem. I'm going to explain it a little bit more. But at the end, I cannot monitor. I don't have human resources to do the monitoring of the HTA decision. I don't have really financial resources also. So yes, the 8 major steps are there, but they are not always respected or really all taken into consideration whenever I'm establishing a new HTA body. What is the most important, or what is considered to be the core of health technology assessment from 1 to 8? Number 1, 2, okay, 4, 5, 6, okay. So all steps are very important. I can tell you, yes, all steps are very important. Now, what we can consider, what we consider to be the core of HTA is the economic evaluation part, because it's really very critical, where we are correlating the health outcomes to the costs. But all steps are definitely very important. One crucial step, one of the most crucial steps is number 2, defining the decision problem. That's why I wanted to put it in a slide to just summarize. So this is the process. It's really all those steps are divided into 3 important domains: identification, evaluation, and recommendation. Whenever I do the evaluation, so it's also what are the 4? So I'm evaluating the medical, the clinical, the economic, the social, the legal, everything. And then I'm setting recommendations and monitoring. Whenever I'm deciding here, whenever I'm identifying the decision problem I have, which is number 2, then here I'm using the famous, I don't know if you are familiar with, we use it a lot, the PICO element. The PICO framework is P for population, I for intervention, comparators, and outcomes. Why? Because whenever I want to assess a new health technology, so I might say, I have to define my population. Is it a triple negative breast cancer? What line of treatment? After failure of what? What is the new intervention? Is it a new drug, a medical procedure, a health policy? So I have to know everything about the new health technology. And the comparators, So what is the standard care that I am using and what are the outcomes? So do I want really to have a better efficacy, less adverse events, or I want to go through cost effectiveness? So this is to say that I can have an HTA body, but I'm not really doing cost effectiveness. Is cost effectiveness mandatory to have an HTA? It's definitely a difficult topic, right? A little bit, maybe it's the first time we're talking about HTA, it's fine. So the HTA is not, we don't have anything which is mandatory. It's the way we want to assess the new health technologies coming to the market. So basically it's a no. We can decide what we want whenever we're doing the assessment. And if I want my product to be on the market, if you want new health technologies for your patients, so first, you have to ensure safety. And second, you want to ensure efficacy, excellent. And third, you want to ensure quality. And then cost effectiveness. And I'm sure you will know at the end if my product is safe, if my product is efficacious, if my product is of good quality, and if my product is cost effective, what will be needed in order to have this product accessible to the patient? I need one more step.
That's affordability, whether
acceptability, acceptable.
Acceptability.
Legislation.
Legislation. Okay, but legislation are linked to all of these. So basically, if I want the product to be accessible, the legislation or the policy at the level of the government will tell you, I want the product to be safe. I want the product to be efficacious, to be really of high quality, to be cost effective to me, to show me value. I want to know what I am paying for. But I have to add,
I think affordability, whether we can afford to provide that treatment.
Excellent, and this is it. So basically, this is the whole story. It's not rocket science, HTA. The way I want to assess the entrance of new health technologies into my market. So basically, this is the answer to your question. So budget impact is more related to affordability, where you have cost effectiveness addressing value concerns. Okay, so key principles of HTA, we won't go over key principles. They are really tough and I will annoy you. How many key principles? So just to remember that we have some key principles, very important. How many of them do we have? 8. Okay, Dr. Affat, 8. In UAE, it's 8. Okay. So, okay, we have 15. Now, the 15 are more related to the structure, the methods, the processes, and use. It's important to know them if I want to have an HTA. So what are really my key principles? So I will go over them. So basically, it's not really detailed, but just to say that it's transparent. We have to consider transferability as we said. So HTA is not something which is transferable. In some really very specific cases, we can do it. And it will involve all key stakeholders. It has to be monitored. Have you ever heard about a drug which was reimbursed in France, for example, and after a few years, it was delisted? It's not there anymore? Have you heard about such cases? It can happen, and it is due to HTA. Okay, so I will jump to the part of HTA around the world. Maybe it will be more interesting to see how the story of HTA was. So you know that whenever we want a health technology to be on the market, the first step to do is to do the registration. Where the registration is being done at the level of? Exactly, so FDA, which is the regulator. So if I'm talking about the world, so it's FDA. And now in Europe, it is called EMA. Yeah, it's European Medical Agency. Thank you. So a long time ago, we didn't have EMA. So basically in Europe, it was like the national agency, the Ministry of Public Health, like it's happening in UAE, is doing the registration. It's based on cost or it's just based on safety, efficacy, and quality. And then the payers will decide about the reimbursement. But through years and through time, payers were confronted to several challenges. They don't know what to decide, and really the burden of chronic diseases was there. So HTA was created in most of European countries, tackling the part of effectiveness, efficacy, ICER, which is the incremental cost effectiveness ratio, etc., economic evaluation. And we have the payer side. What is the difference between like efficacy and effectiveness, do you think? It is population-based versus? Okay, so in the HTA concept, we consider efficacy related to RCTs, where we really are doing randomized control trials and we are assessing the outcomes related to this. Effectiveness, it's more related to the efficacy in the real world evidence scenario. So I want to generate more effectiveness throughout the years where the product is on my market. And yet we had the EMA, so you had EMA, so this is the process to funding and HTA was there. At the end of the assessment, we will be having a report, and this report will tell us, yes, the product is reimbursed, but in specific conditions, and we will have some positive lists to be issued. This is the history or the historical development of HTA through years. It is everywhere. So what is important to say that yet first it started in the US, but it failed the political will and support. So we don't have really an HTA governmental because, as you know, the healthcare system in US is different than the healthcare system in Europe. And after that, we had CADAF in Canada and PBAC in Australia, developing really very good economic evaluation adopted by NICE in the UK. And after that, we had IQWiG in Germany, HAS, etc. UNITA, Dr. Muhammad was talking about it. So UNITA is the European Network of Health Technology Assessment, where all health technology assessment bodies are joining their efforts. We have the international one, which is called INATA also. The WHO is urging all members, even in MENA, and helping all governmental sectors to create their own HTA, even starting by a small committee with certain capacity building in order to enhance the science and to inform better decision making. Now, this was the chart we discussed. So my question to you will be more into the results of HTA. I did the HTA. I did the clinical part, the economic part. And the first is, like we said, is a no. We don't find any reason to reimburse it. 2, it's a yes. And 3, we said that it is cost effective, but it is not affordable. So it's a good product, but I cannot afford it. What could be the solution? We deprive the patient from access, or we try to find other solutions. So, yes, you want to say something? This is our job as healthcare decision makers. So we have to create some things, but it's really not affordable for us. What about doing some sort of agreements between healthcare decision makers and manufacturers or providers? So that's why managed entry agreement is another science that will complete HTA results, because we won't stop there. HTA is there giving us so many research and evidence to say at the end, yes, no, or yes, but agreements are very important. If we look at types of agreements, we have several types of agreements that might be financial based, performance based, but I want the product to reach and to be accessible to my patient at the level of the country, but I will do a sort of agreement with the manufacturer, and this is the role of managed entry agreements. Now, this was an overview of all health technology bodies over the world. And if we look at HTA in the world, so you can see that we have formal HTA and informal HTA. Why do you think we name them formal and informal? What could be the difference? Governmental involvement, okay, it's interesting, but in the two, we have a governmental involvement because they are officially HTA, like AIFA in Italy, it's a very famous HTA. So, and it's considered to be informal. What is really the difference between formal and informal? We talk about formal HTA, informal HTA. What could be the difference? So the criteria, Yes, and excellent. Yes, because we talked about the process and we talked about the principles. One of the principles that we have to have it published. So results of HTA has to be published and transparent. If it's not really 100% respected, then we consider our HTA to be informal. It's not bad. It's not something which is bad, but it is informal. It's like a terminology that we use. It's the way we do it. And policymakers, decision makers are free to decide what they want to adopt. So basically, it's you can see that France is publishing results of, you can see them. You can even check the meeting date of the committee, of the HTA committee, whenever they will meet in order to discuss a new product in breast cancer. So you can see it. It's very transparent, so that we know that we have formal and informal ones. What about the key decision criteria? We said that HTA is different in several countries, right? So key decision criteria is also different. Where I say, for example, France is more concerned about the disease severity, the unmet needs, efficacy, safety of the product. So France is looking more into an absolute therapeutic value. Is France oriented into cost effectiveness analysis? No, but HTA is there. So it's their way of doing the thing. Germany is more clinical, relative therapeutic value. They want to see an added value whenever they are clinical value, whenever they are comparing the new product to the standard of care. UK is more into the cost effectiveness. It's a key decision criteria. So basically, if it's cost effective, it's a yes. If it's not, they would go into a managed entry agreement, more focused on financial based, which is the discount in this case. Does it make sense? So if I want to do a UAE HTA or Saudi HTA, key decision criteria might be different. It's not the same. So it really depends on the system and the type of the healthcare system that we usually have.
I think that the addition the UK have, they also have the public health aspects of these interventions. So they include at least, I think, 60 topics on public health itself, which is not therapeutic at all. So yeah, this is all about preventions and making sure our population is protected in that sense.
You mean it's more national, at the national level, so they have the whole population, and this will facilitate HTA implementation. Whenever the system is fragmented, we have several issues. For example, Spain is one example of fragmented healthcare system. You have many systems, so you don't have like one insurer, but they have many HTA bodies, so in every and single national. So for every single healthcare, we have the special context of HTA, it's exact.
And certainly in the UK, the NICE produced, in the end of that process, they produce the guidelines, what need to happen, right? So obviously there's no funding attached with that one. So that is up to the Department of Health to decide whether they want to implement those guidelines and where the money is going to come from. So the payer is separate from that decision-making process itself. So these organizations, they produce guidelines and they ask the hospitals or the healthcare providers to include that service as a part of the quality of that service. So that's how it gets introduced into the practice, to improving the quality of the care.
Okay.
Yeah, that's the process in the UK.
Okay, thank you. Thank you for sharing this. I have some points to add maybe at the later stage or in the panel. Thank you for sharing this. This is to say that the key decision criteria might be different, but they are all doing what we call managed entry agreement. If we just look at the end, we can see that all types of managed entry agreements are there, and managed entry agreements are different depending on the negotiation and the findings of the HTA analysis at the level of the country. Now, moving to HTA in the MENA region. Do we have HTA in the MENA region in any of the countries? No, we have seen that. Just to recap, so HTA is there. It's not something which is very new. It existed long time ago. It's the way we assess new health technologies. It's relying on 4 domains or 5 domains, from clinical to medical to social, ethical, and legal. It is implemented in several European countries. Most examples are HAS, Haute Autorité de Santé in France. We have NICE, we have EQUIC, so in Australia and Canada, and now in the MENA. Do we have HTA bodies, or do you think that if I ask, for example, UAE, do you have an HTA body, or do you have the HTA science into your institution? So what is the answer? No. Okay. Okay. Sorry? Yes, yes, and it's promising. So basically, to answer the question, that every healthcare decision maker has its own way of doing the assessment. So basically, HTA is there. It's not something which is very weird. So maybe they are deciding, maybe Dubai Health Authority are deciding on the least priced product or drug in a therapeutic class. It's the way they are doing it. Is it formal? No, it's not. So the answer is, yes, they have their own way to do it, but it's not really the formal way, and it can be enhanced in a way. Do we have an HTA body in the MENA? Yes, we have one. The first one that was like established was more related to what country? In Lebanon, we used like HTA for 10 years, but it was not formal, so results were not published. And after the HTA use as a tool, we implemented like more than 70 managed entry agreements, accessing, giving early access to the patients, and doing more than 100 patient support programs. And it's really, it happened because of the use of HTA tool. Okay, I will put maybe, okay, so choose, you can pick and choose. Saudi Arabia is like now, they implemented a framework. It's not yet used in a formal way. They write it down. It's very new, and they are waiting for the cost effectiveness threshold to be published very soon. But we had one. Choose from those countries. Okay, it's easy. Tunis, excellent. Yeah. Yes, exactly. Tunis, because they were really supported by France, Haute Autorité de Santé, and they established their own, and they have written the health economic guidelines related to them. And this is very important because they are issuing templates for the manufacturers to fill, so that they will have a standardized approach whenever they will do the assessment. So Tunis is one. Others, so in Jordan, for example, what do you know about Jordan? In Jordan, you know the King Hussein Cancer Care Center. So they use the HTA whenever they assess new technologies. They have published report on cost effectiveness analysis. And in UAE, so we're congratulating now the HTA. So Dr. Muhammad, you want to say something?
Yeah, thank you. Thank you very much, actually. But I think in terms of the existence of HTA in the region, I really doubt. Yes, there are ideas here and there. There are ways by which people are taking decisions. And but proper HTA is still really missing because it requires scientific evidence. Of course, people can dig scientific evidence the way they like. That's not a big issue. Cost effectiveness, I doubt it very much. Transparency, seldom or completely non-existent, and most of decision making is going by interest. Let us face it, by private interest, by interest which is hidden interest, and conflict of interest is always there. There is no mechanism to avoid it. Okay, and so it is so big question mark, and that's why I think if we wish to see HTA expanding in the region, I think these issues should be addressed, importance of the scientific approach, importance of transparency, and importance of also independence of the HTA bodies. I don't really consider an HTA body, which is part of the decision maker body itself, an independent HTA. Yeah. So anyway, we are in an academic institution that is independent.
Yes,
so,
sure. Thank you for sharing this. Yes, it's still early maybe to say that HTA is well established, sure, in MENA. It's not something which is very easy to be done. But when we see that, for example, Dubai health authorities are moving towards value-based healthcare, Dr. Sarah Dalal will be with us in the second session to present also some work done at the EHTA conference, which is promoting also health economic science. And I was the president of the ISPOR Lebanese chapter, and ISPOR's role is also important, universities' role, societies. So all joint effort is really very important to spread this knowledge, because we lack knowledge in the region. So basically we can say that we don't have really so many even publications on HTA in the region. Do you know how many publications we have in the region throughout the years? So we have like an average of 7 to 10 maximum publications in the whole region, and this is really very low. All the joint effort and key considerations, if we have some learning lessons to really just remember, is that one, HTA capacity building has to be strengthened by more graduate and postgraduate programs. So we don't have so many postgraduate programs in HTA in our region, right? And second, the role of local evidence. Whenever we want to do HTA, data is important. We need to have local data, local costs, local data on our patients, and this should be enhanced. Third, duplication of efforts can be reduced if international collaboration is integrated into a national HTA implementation. So why to duplicate efforts if we can merge some institutions together? So all those three key considerations are very important. Finally, what is the most important are some key considerations to just think about it. We don't need an HTA if we don't have any problem. So before starting any HTA, we should just ask ourselves why I am establishing an HTA body. What are my questions, concerns, and challenges? Maybe I don't have any challenges of the challenges I have just mentioned before. Who will budget it? It's costly. HTA is costly, right? And it's lengthy. So how can I budget it? So who will pay for it? I have to ensure a certain mechanism to do it. And do I have enough capacity in my own institution? So I sort out a decree and a memo saying I have to have an HTA in my own country, but I don't have a trained team. I don't understand the language of it. So we have to consider it. We have to define the process, the mechanisms, what key principles are we adopting? We have also to consider involving network and experts with experience and identify and involve all relevant stakeholders with us. As much as your joint effort where we have government sector with research, with universities, with societies, this will enhance the skill, will reduce the duplication of effort, and will lead and will be having higher chances of success. So I guess I finished the presentation. To conclude and tell you that thank you so much for listening. I don't know if the topic was hard, but we are ready to answer any question that you might have. Thank you.
Thank you very much. Thank you very much. I have my... Shall we leave the questions until Dr. Sarah finishes her presentation? She's with us.
Because she's waiting,
she's
right?
Waiting for us.
Okay.
And, I will stop sharing our screen. Dr. Sarah, I hope you're able to share your screen. I can see you. Welcome to this session. So can you upload your slides kindly?
Hello, Dr. Sarah. We're seeing you.
Hello, everyone. I hope everyone is doing well.
Great, great. I stole a picture of you from the net and I was going to show it, but it's better that we have you live here. So
no, I would like to see the picture that you stole, if you don't mind. How is everyone doing?
Dr. Sarah, you know her, and sure, Dr. Affat will be presenting her. But this is a real example of really joining efforts from the government perspective, society, and also university. And this is really very important for the success of any project. So, Dr. Sarah, we're happy you're here.
Is that you, Dr. Sarah? I don't know.
Yes, it is me. It's on my Twitter account. That was my younger self years ago.
Okay.
Thank you. Thank you so much, Dr. Affat, and thank you, Dr. Mirna. And I would like to thank everyone because I'm not being able to see your beautiful faces on the other end, but I would like to, Dr. Affat, maybe you'd like to start by introducing myself, or should I introduce myself?
Can I introduce you?
Definitely, please go ahead.
It's up to you.
No, I would love you to introduce me, and I would love to know that I'm a graduate of the CMHS. So I'm not sure if many of my professors do recall me from the day I was a student at CMHS.
I don't know if we have Dr. Muhammad Sadiq. He's been here for as long as the university has been here. So you might know Dr. Sadiq. We had Dr. Hokani, but he left. I hope we will see you in person, and you will come and visit us here in the college, and you will see the professors face to face. So Dr. Sarah is the president of the Emirates Medical Association, Emirates Health Economics Society, and a specialist in the Dubai Health Authority. She's a medical doctor who graduated from this university, and I was so pleased to see that from the College of Medicine and Health Sciences. She completed her internal medicine residency in the Dubai Health Authority and holds a master's degree in healthcare management from Royal College of Surgeons, Ireland, and master's in health economics and policy from London School of Health Economics. And I'll leave it to you if you would like to say anything else about yourself, Dr. Sarah. The floor is yours. And thank you very much.
Thank you, Dr. Affat. Thank you so much for this kind introduction. I don't have anything else to add besides that I enjoy eating. So I know I'm keeping everyone a little bit out. Probably by this point, everybody is hungry. But I would like to introduce myself and the humble society that we have. The Emirates Health Economics Society. The Emirates Health Economics Society is fallen under the umbrella of the Emirates Medical Association as a subliminal or a subcategory of the society, and it's a non-profit organization. And actually, there is not much to be said about it. We do have a website, which is Emirates Health Economics Society as an acronym, EHES.AE. And it has multiple things in it from the day we started until today. So we started, let's say, at Q3 2020, and these are started with CME accredited hours, and these are the activities that I would like to show you that throughout the last 2 years, there are certain things that were done in a webinar format, and there are certain things that were done physically. So we started with the first session, and it was about what is health economics. And funny enough that in the first session that we have done it online, we got over 500 participants. Now, these are not all our members. Our members are almost less than 50 by this point. But what we anticipated is that we started doing some knowledge sharing with our groups and networks, and slowly but surely, so people are interested in the topic. Probably the topic was gaining a bit of attention because in 2020, all of us, we were going through, let's say a history of things that was happening and shaping the whole world. So many people were under lockdown, many people joined us virtually. So the first couple of sessions were done as a webinar format, and it was in a CME format. So it was more of testing the waters, what could be health economics. There is something that I would like to highlight, and it's usually what people try to let's say, confuse or probably think health economics has to do with, for example, financing or investment or anything that has to do with money in a healthcare system. In fact, it's actually economics is the disciplines of how you can make best choices. And because the value of making a best choice may include in our recent world is money. It has nothing to do with financing, investing, or putting plans, financial plans for a certain way. Health economics help you to take the right decisions to put in these financial plans and not the other way around. And most of the topics that you will see, and we have to acknowledge this, where today the whole discussion is talking about HTA and medical technologies and medical innovation, which is in particular goes with the pharmaceutical industries or the drug reimbursement industries. And with HTA and what has been said from the morning until just a few minutes ago by Dr. Mirna, about how a value proposition is been handled is usually health economics is almost been promoted as or been confused with pharmacoeconomics, whether it is cost effectiveness of a certain drug or a budget impact of a certain drug. Now, HTA agencies also, or health technology agencies, and I do acknowledge what Dr. Mohammed Al-Sadiq is saying. First of all, there is not one size that fits all, and it's very contextual, and the topic of HTA is quite varied. But after I show you the presentation itself, that these were the activities. There was a soft inauguration event where we have introduced the importance of pharmacoeconomics then and how it's distinguished from health economics as a whole was one of the things that we have discussed. And in there was the value framework of introducing innovative frameworks that was entered. And that was at the tail end of the 2020. So why then our members, and we call them our ambassadors, starting to understand the terminologies that maybe individuals who are really interested in health economics looked at. But as we went in, we looked at how the health economics, for example, is related with policy making and policy decision. And this is where we try to make health economics used as a tool when it comes to decision making. Like in the Emirates of Abu Dhabi and in Al Ain, there is a program, or there's a payment model called DRG. So we try to make sense of all of that. There's also priorities and strategies set aside in the healthcare system with value-based healthcare. So with that, we are promoting the health economic part of it. And as we went by, we started discussing more and more about primarily, and I have to say this, were done locally and produced locally as a research, and we started highlighting the value of that. Because we didn't want to introduce the idea of a health technology assessment. We wanted all our members, anyone who could be a student or somebody who doesn't even work in the healthcare sector. And we found a lot of people who are not in the healthcare sector, but economists per se, would be joining us to understand what is the measured value that we need to take it in and really contextualize it in the region. So we started branching there from looking at health policies and health insurance, and also looking at what is the role of the patients in the whole equation. So besides that, we have done a lot of activities, and this is something to do with the society itself. We looked at other activities. There's a lot of initiations. Some of them are social, we don't post them online, and some of them are looking into promoting the first the national strategies of the Emirates itself, and we are looking at pressing matters that needs to take a decision into that. So there are lots of things, like for example, we looked at vaccines, and we were there with upfronting the vaccines and how we can, I mean, in certain matters probably discussed earlier, we don't need to do a full value proposition for it or value appraisal for it, but we wanted to add our voices in terms of universal health coverage being a tool to be looked at and to be thought about, that it is economically, it will have spillovers on the whole economy in terms of policy and even the vaccine itself. And from there, we looked at other areas that we wanted support in. And these were the first year, and we kind of at the end of the first year, which is almost 1 year ago, we had our first Emirates Health Economics annual conference. And it was a small conference of 2 days. It was in a hybrid format, and the recordings are available online free on our website. And it talked about how we can have a sustainable future. And the agenda was totally different. We discussed financing healthcare from a broad and long-term perspective, and then we looked at certain pharmaceutical areas where it was more discussing about the triad when we look at the health financing, which is the payers, the providers, who is taking the decision makers, and there was a strategic healthcare financing workshop that looked into that and probably addressed what could be done in terms of value and promoting value, and is HTA the route to really be implemented in the sense that is available now. Now, I am sure that there is colleagues available with us in this virtually who are representing the Abu Dhabi Department of Health, and they have a dedicated unit, the HTA unit, which has done a tremendous job during the in the last 2 years, almost 2 years, and I will not talk on their behalf because I will not do them justice, in terms of how value propositions are looked into in a very particular way in terms of the medical devices and medical technologies. We have to think about the contextualization of the context itself, in terms that the UAE is best positioned in a way where adoption of technologies are different. And since then, we did also a lot of activities that was on ground. And just a week ago, we had our second Emirates Health Economics Conference, and we had lots of participation from the region to discuss lots of pressing matters, and in terms of panel discussions. And this is Dr. Mohammed Al-Sadiq. Sorry, we have shaded you. I hope you can spot Dr. Mohammed Al-Sadiq. Can everyone spot Dr. Mohammed Al-Sadiq and Dr. Fatma Sayyah? I'm not sure if you're seeing the slides very clearly. And as you can see, many health economists were available from different regions to discuss how we can shape. Colleagues from Saudi Arabia looking at the roadmap actually of implementing HTA in their areas, and soon they will be presenting their cost utility scores and the cost effectiveness thresholds. So this was the picture that we all had, and during this conference, if I would like you to spot what we were promoting during our conference, is this picture really represents all of us that we are joining all together. And that's not the only thing. We are representing that, that we are supporting also the color vision deficiency program, where colorblind people, the whole conference was sustainable in its premise. And it promoted that all the slides to the maximum, and everybody was wearing attires, and they contributed in that. that is really supporting the color blindness or color vision friendly palette of colors. So this was basically the Emirates Health Economics Conference that was done into there. And we would love to see you, inshallah, all of you, to join us in our conference as our ambassadors. And we will be also really happy to have you as being our ambassadors. Thank you so much. This is myself, and I'm shocked that they added this as my last picture. So now you're seeing me in dual, in two pictures. And this is where I stop sharing my slides. And I hope that oh, now I get to see the whole crowd. Dr. Mohammed Al-Sadiq, hello. Dr. Grivna, I haven't seen you for a long time. And I cannot see people in the back, but whoever recognizes me, Dr. Mirna, I can see you on the side. And I mean, I would love to hear from all of you. What, I mean, today, I know it's a small, let's say, a presentation, and I am so happy that the society itself is promoting EQ5D as a tool, and I'm so happy and I'm so glad that UAE University is doing that, and we are looking at the sampling in a proper way, and which is giving it legitimacy. Now, this was a discussion that we had probably 2 days ago with the team, as our EQ5D will be very particularly different than many places in the world. We are quite unique. Our system, our healthcare system is totally different. And I'm so happy to be part somehow of the study, and also to promote the study to the best maximum ability. This will open a lot of doors. This will really bring or shape up the discussion to be on a higher caliber and on a higher level. And thank you for whoever is directing the video cam, because I'm able to see everyone. And for me, actually, I would like to hear from your side, and to be very honest, the efforts that we are doing at the moment is really to bring the caliber high up. And maybe there are certain things that we are seeing it from one side, that we are not being able to meet demands, and all what we are trying to do under any health economic umbrella is to meet your unmet needs. So today I would love to hear how can the society, with all its let's say capacity, can help you to bring that forward, how it can help students to really take them forward into that. We are more than welcome to collaborate, and that's me. I think I'll end up with that, and thank you so much for hearing me babble and a lot.
Dr. Sarah, that was great, and I hope you can stay with us for another at least 15 minutes. I will invite Dr. Fatma and Dr. Mirna and Dr. Sadiq to the podium here, or to the stage, to have some discussion with the audience, those who are in the room and in the virtual metaverse there. So please, we will dedicate at least 15 to 20 minutes for discussion and for questions and answers. Please, I'll give you the mic, I think, yes. So there was, I think so many of you had questions. So let's start with, Dr. Mirna, will you moderate? That was the yes.
Ask myself questions.
Yes.
So
that was the decision. He said you're an excellent moderator.
Oh, thank
she was
you.
excellent in the forum in the
Okay, so basically I am not the one who will answer the questions, so I will get up.
You can answer.
So first, thank you so much for this really amazing first session in the UAE University on the EHTA. We have on board academicians, we have regulators, and I'm sure that we have online several other hats from the UAE. So first, let me open the floor for any question. So virtual or from the people with us today. So do you have any question to any one of us here? Oui, yes.
Thank you very much for these great presentations. So I understand here that you are trying to get favor of one drug over another for single treatment for certain disease. But in low-income countries, it might be relevant as well to how will you be able to use these models to, if you wanted to favor a treatment of one disease over another, not just a treatment over another, but one disease over other disease.
Okay, in specifically in a low middle income country, or you are talking about any healthcare system?
Yeah, in low income countries, and maybe relevant also to middle income countries, especially in the diseases which cost very expensive medication.
Okay, so I will answer in a nutshell, and then all of us will have maybe some answers. So basically, this is very important what you asked, because the first thing to do is to set the highest disease burden. So what are the diseases that are really impacting the society? So that's why it might be different from a context to another. So here we are not comparing a drug to a drug in a specific disease, but you are prioritizing in what disease you want to start. And when we are really talking about HTA, for example, one of the key the step one, in fact, in all the process is just to really decide about the priority of diseases that you want to tackle. Why you have chosen to hepatitis C and not really focusing on oncology? What are your preferences? So here comes the analysis of the government to say that data of and my internal data showed that I have a high economic burden when it comes to oncology treatment. So I have to put it at first and start by analyzing the disease management pathway, try to see if the patients are really responding, try to find abuse in a system or off-label uses or whatever. So we have many spendings. So it's very important. It's step one if I want to answer the question of HTA. And here, Dr. Sarah, Dr. Fatima, Dr. Muhammad, if you want to add on this.
Thank you. Thank you for the question. I think as hinted by Myrna, yes, of course, the objective in the low and middle income countries may be how to prioritize, diseases, the disease burden, and which ones should be tackled first, and which programs should be favored against which, and so on. And so the measure, I think the common measure in use in low and middle income countries, and as recommended also by WHO, is to use the disability adjusted life years. I think that is a measure of preference in terms of prioritization, if that would answer your question. We cannot so far tend to use quality adjusted life years, the health quality utility measures for the low and middle income countries. The priorities are different, and the approach, I believe, is very much different. Thank you.
Does this answer your question? Thank you. Yes. Yeah, Dr. Sarah. Yeah.
Can I add something, because the context really plays a role when when, let's say, we're talking about what is lower middle income countries and what is not. Now, I do believe the priorities really set a good indication of what to go for when it comes to HTAs. But also there are certain things, to be honest, I mean, we have the experts right here. Have you ever seen an HTA agency, whether it was lower, middle, or high income countries, that has done it right from the beginning? Or they have set their priorities right from the beginning and they got it right, at least almost right from the beginning. The methodologies may change and shift. I'm not sure Dr. Mohammed Al-Sadiq, Dr. Fatma, Dr. Amirna can really look into that. But when it comes to lower income countries, maybe the full HTA or how the priority setting may look different and may not necessarily rely on the typical way of an HTA. So that's my own input on the matter.
Thank you, Dr. Sarah. So this is very valid. And we have evidence on it in our region where HTA is not really formal, as we have just mentioned, but we started it very different, and priorities were really very different, methodologies even adopted, and we can discuss it further. Dr. Fatima, you wanted to add something?
As I'm just listening to the conversation, just keep coming to my mind also, I think Dr. Sarah tapped a little bit into this. I think it's good to remember that this is not just one way of doing things. It's an added tool to how decision makers can make decisions. There are many situations where you don't go through an HTA process, depending on the context. Like you were talking about low-income countries, there might be certain diseases, and it doesn't matter. Like if you think about, for instance, when COVID started, the government here said, everybody who's going to get a PCR test, we're going to pay for it. That's a cost. That's a technology. But the context was very different. It's not your typical context. The decision was made in a very different way. So there are different considerations. And there are many other things, areas where the process looks different or the decision-making process is different. In rare diseases, for instance, you may have 5 people in the country who have a rare disease, and the treatment costs $1 million per patient. It's definitely not cost effective when we do like an economic analysis, but the decision is not based on that only. There's so many other considerations. The prevalence of the disease, how many people will be affected, which age groups, is this in pediatrics, is it in adults? There's so many other considerations. That's kind of the, I'm just kind of expanding on what Dr. Sarah said in terms of the context. It's way beyond just, here we're talking about a technique, how to do it, but there's a lot around it that has to be considered by a decision maker. So it's good to keep that in mind.
Yes, thank you. Thank you, Dr. Fatima. Yeah, another question? Yeah. Okay.
There is already some question typed. And so if you, those who are online, if you type your question might be
yeah, so yeah, for the people joining virtual, if you can please write the question down so we can read it and answer it. We're sorry for that because it will create, it's easier, yeah. Okay, so we'll take the question of, it's fine, so we'll go with your question, please.
Okay, thank you so much. I mean, it's very exciting to hear about, you know, the whole health HTA, and it's exciting to see it here and happening. But I mean, one of the, I'm not being pessimistic, but I think one of the biggest challenges that, and I think Dr. Sarah's presentation sort of reminded me of this challenge, is it starts at the level of documentation, okay? And if we are going to be able to provide the evidence of how effective something is. And we had the question about, you know, how do we know that a disease exists, whether it's low income in country or a high income country? I know that in this region and in low income countries, documentation is not as maybe stringent as it is in other parts of the world. Dr. Sarah mentioned, I saw in her presentation something called the DRG, and if I'm not mistaken, Dr. Sarah, it's the diagnosis related groups, which I have worked with before I joined the UAE, and you know, it based the case mix of how health, you know, insurance, and how people were reimbursed economically in terms of health expenditure. So again, that sort of reminded me that we really need to also, it's great that we have these systems, but really emphasize the importance of correct documentation, specific documentation, medical documentation, how it's coded if we're using international classification of diseases and so forth, in order to give us that accurate information about expenditure, about what diseases are being used, how specific it is. I mean, from my experience so far, when I look at, you know, ICD coding here, for example, it's not specific. It's very broad, it's very general, and the expenditure of somebody who comes in with cardiac arrest, for example, and a patient who comes in cardiac arrest with so many other complications which are often missed in documentation is going to be very different. So I think that's something that we also need to be, put into the framework of when we're trying to adopt a good and effective HTA.
Yeah, thank you. Thank you for the question, Dr. Sarah. If we want to relate the question to maybe the strength of the data that you have at Dubai Health Authority, or that you are trying really to use in order to enhance evidence-based decision-making or policies based on the priority set and the strength of data you have.
Sure, I would like to elaborate on this because I'm talking on the behalf of both. I'm talking in general in the Emirates itself. I think that we have seen lately that there are lots of electronic health record systems being implemented on the UAE. Like in Abu Dhabi, there is Malaffi. In Dubai, there is Nabal. And in the Northern Emirates, there is another system that is being implemented at the time being. But that doesn't mean with the DRG system, probably I would go back to your question, Doctora. We have big data, and I'm talking about there is a very stringent way of coding. There is a coding manual, and we are all talking and delivering the same message when we are talking about coding certain matters and also getting reimbursed for certain matters. These are available online, and you can log in and you can see it. And why did I mention the DRG? Because for us at that point, DRG was just released in Dubai, and it was something that we were highlighting as a health economic way that, listen, don't panic. There is a case mix. You will get the return of investment one way or the other. Don't panic. We looked at this as a justification. Don't think that we didn't do it. This is the calculation itself. Yes, and then we took that and we looked at the value proposition. So there are other things in terms of, but if you are looking at the processes and procedures, the HTA itself, and I would like to recommend to have a flavor of documentation itself and what is required, what is not required, what are the RWE or real world evidence data that would be required and how is it captured. You can check them through the websites online. And I'm not sure if the colleagues from Abu Dhabi Department of Health, they have the registry of all the technologies. So this is a good way that you can go on there and see how is it coded, formalized, presented to the public in a way that you can understand that everything is visible, transparent, clear, and we are ticking the boxes. There is a long way to advance and make it much more automized and look at the whole cycle. But we, as the United Arab Emirates, there are lots of efforts in capturing the data. Where in Dubai Health Authority, big data is a thing. You have basically, you're capturing every part of the patient journey in Dubai on an electronic health record system. With the payment,
I may just add just one quick comment because I don't want you to be pessimistic about where we're at, particularly around that. Cardiff in Canada, our region on the outcome, we jump, we just want it to happen, but it's a process. And one of the, there's so many blocks to build that infrastructure. The data is extremely important part, but this conversation that we're having today is about raising these issues and saying, okay, these issues matter. We need to work on this. We need to work on that. We presented this study. This is a very small building block in being able to do a cost utility analysis at some point, local one. Mina discussed a lot of other things, but I'm very glad these issues are coming up because this is what helps us think, okay, how can we take this to the next step? What is it that we need to work on? Is it capacity building? Is it data? Is it this? Is it all of these things? So it is a process. And I think where UAE is at this stage, I think there's a great potential for this process to move forward in a really good pace, at least, compared to other places in the world.
Sorry,
can I remember everyone that many of these countries started without data. Now we have a platform where we are gathering data. Maybe it's not the right type of data, but it's much more easy and integratable. So thinking about it in a way, sorry, Dr. Alfat, I know what you would like to comment, but we are blessed that we saw others. They took steps before us. We can take the learning points from there, and then we can, as we move along, we can take that and we can have these discussions. Maybe certain things are a priority to yourself rather than ourselves. And this is a good medium that we have everyone together to really work towards it.
In fact, I wanted to ask if we have any of our virtual audience from Abu Dhabi Public Health Center and they would like to comment on, they have anything to add, because if there is anyone, they can raise, just open the mic or just raise their hand. Yes, please.
Thank you. An informative session today. My question is going to be a little bit based on the execution of the program and the conjugation for the Emirates Health Technology Assessment Research Unit. For example, if the unit is creating the one document, HTA document, then how it's going to be executed or bridging the gap with the national agency, for example? Is there any interaction between the research unit, between the Dubai Health Authority or any other insurance company? So is there any connection has been developed, or what is the plan for the future for the external stakeholder? Thank you.
Well, I wish that a colleague from DOH or but we have Dr. Sarah with us here, and she can give shed some light on this. As far as I know, so far, there is no like a straight or a clear-cut, formal recognition for HTA agencies. And in fact, actually, within within the UAE, the only HTA agencies out of the Ministry of Health is ours so far. So, and we are trying to establish, and we are in contact with DOH, at least with also DHA, and so on. So, as mentioned, I think by Dr. Fatma, the whole setup is just like taking shape, and it is building up. Thank you.
Yeah, so basically, if I just as external mention that we cannot like just wait for all the capacities in order to build HTA. We have to start by really the needs that are assessed at the level of the country. Now, what I can see is that initiatives in Abu Dhabi, for example, the Department of Health setting a decree in 2021 mentioning HTA or economic evaluation when presenting a dossier is something, because even if the capacity is not here, human resources, but they started with a certain political will to enhance the way they are assessing it at their pace, their own. Dubai Health Authority, Dr. Sarah, moving to value-based healthcare, having some programs like EHTA program in Dubai, where real-world evidence generation, really managing the disease pattern based on health outcomes. So all those initiatives are really very important because they are addressing needs and moving towards a better deciding about adoption of new technologies. It doesn't have to really fit, like we just said, all the process, ideal way of implementing it. But what is really needed, and I can say it, based on all the experience I had whenever we started implementing HTA, is that as much as there is collaboration and not really to duplicate effort, it's important. So having colleagues or having experts from Abu Dhabi and Dubai and all Emirates and Ministry of Public Health is very important to join effort with university researchers and expertise on board in order to enhance the way the decision is made. And this is for the best of the patients. So every single effort is there to enhance and access in a better way new health technologies to the market of UAE. Yeah. Perfect. Perfect. Okay. He raised his hand.
Yes, good afternoon. Thank you so much for inviting us, and we're really glad to see this meeting. I met yesterday with Dr. Mohammed, Dr. Michael, so we are really pleased to see this happening. I think we have our colleagues from the HTA team here connected. I'm a health economist and I work as a chairman advisor here at the DOH. So we can talk about more specifically the plans for the HTA unit at the DOH. But I just wanted to point out a couple of things. So which one is, first is, I think it's really important to have the expertise and the support that we're establishing with this initiative at the UAE University. So we at the DOH, we are, as you know, the regulator of the health sector in Abu Dhabi. So we are in charge of ultimately defining which technologies need to be adopted and reimbursed. However, we are usually not equipped to do that in-house. So we need to rely on the support from qualified experts like you that can really take the work of collecting the data, analyzing the data, and really, very importantly, defining the priorities of where we should invest our limited resources for research. That's something that often we emphasize in health economics, the fact that even our research resources are limited. So we also need to prioritize not only the money that we spend on the products themselves, but also which research we want to prioritize. So it should be really important to see the collaboration developing. And yesterday we were talking about a few clear projects that we can start to collaborate. And by all means, I think the EQ5D initiative that was presented today will be absolutely critical to enable us to actually conducting reliable health economics research in the country. So we are really, my congratulations for this initiative. The other point that I wanted to make is we talked a lot about health economics assessment or the economic evaluation side of HTA. But we also need to acknowledge that health technology assessment is a much broader encompassing process. So it also includes things that a lot of things that need to come before you get to the point of you're looking at the cost effectiveness assessment, and including, for example, how do we incorporate the views of patients? How do we make sure that their interests are reflected? And I think this is something that we shouldn't neglect. I think that the health economics is the more interesting part that gets people excited about qualis and dalis, but it's only part of the picture. And I think we also need to make sure that the rest of the picture is also properly reflected. So I'll stop here. I wonder if my colleague Amna, I don't know if she's still around, but maybe she might want to give a few words about the HTA unit here at the DOH. Otherwise, it's back to you. Thank you so much.
Thank you, Dr. Anderson, for your intervention, and we wished you were here with us today. Thank you for sharing all those info. In fact, maybe I might add that the way of really implementing HTA in a country is really so much specific to each. Now we can learn from some experiences in order to shape it the way we want to do it. But in several cases, it was like outsourced because we don't have really human capabilities and internal expertise, so it's fine. But the other question is that from where can we fund it? So in several CE countries, we can see that funds were from pharmaceutical companies. In other countries, it was like a sort of governmental budget. So there are several ways. It has to be, we can go through different methodologies in really implementing HTA at a national level, but the question is how to find the best way to move, the easiest and the fastest way to answer our key research questions based on, as you exactly mentioned, the data analysis, because the data you have will tell you something, will tell you like really you have a high burden here and there, and we have to tackle it this first and not to lose time while concentrating on other areas of disease. And this is the role of data scientists where they incorporate and include all their analysis in the data. So I wonder if there are some questions to Dr. Anderson. Yes, sure.
As a student researcher who's probably now interested in doing an evaluation as a part of the research, who do we come or who do we meet or who do we approach when we want data, especially regarding the insurance, the cost part of the issue, as well as, so what support can you give or who do we contact for this?
So just to formulate the question, so basically you are concerned to do a study or a research, and you need, so you work in the university, right? Yeah, and for her to access the data, she needs to address Dr. Anderson, Dr. Sarah, or any other presence here from government. So what is the best way to move forward in requesting those data for research purposes?
I can just as you would like to actually request, any request for data is the regular way of requesting to as a research question. So basically you have to submit your research question with the data required to the available health authority I'm talking about, whether it was DHA or whatsoever. And then depending on that, it will go through the ethics committee approval process and the review internally. And then whatever data is allowed and would be shared with the participants themselves. So is it available in Dubai? There is a process that you can check it online like any other research. If it's available, it could be handled as long as it's within.
Yes.
Sorry, Dr. Sarah, did you finish? Maybe so everyone can hear. Yeah. So yeah, I think it's we can comment on this that we hope that the unit that was established here is going to generate data. So we want to have this collaboration with all the concerned maybe departments and concerned persons around the country to come together and generate this type of data that our researchers and future researchers are going to use it. So that's the plan, I think. And this is one of the major plans for the EHTA unit here in the UAE University.
You're right. Maybe I just want to add one important thing is that usually the best way to move forward is to raise the key research questions addressed by policymakers and payers and budget holders, and then the researchers and the HTA unit at UAE universities trying to analyze, trying to search more, dig more, use epidemiologists, biostatisticians, have some cost analysis in order to answer those concerns related to the budget holder or the authority itself. So it's the other way around. Not, okay. Yes, sure. Exactly, sure. Professor, yeah.
Thank you very much. Mine is a general comment rather than the question. First of all, I need to congratulate Michael Griffin and Mohammed Sadiq and his team, in setting up this unit, which is just a foundation and it's a start of the journey, and things will develop further over the years. What I want to comment on is that this whole process takes time, right? So you can't do it overnight or within next few months or the years. So it will take years to develop the whole process. So I can share my experience from the UK. So it started about 32 years ago. So they gave that work to the University of Birmingham to do the health needs assessment. Because for the health technology assessment, you need to know what exactly is the problem with the health for our population. So that's how the work started. So what are the health problems for our population and what interventions we have? Because we have different interventions for different health status, whether they work, how much is the health gain of those health interventions. So then that project was to produce the health need assessments for topics like obesity, breast cancer, eating disorders, severe mental illness. So it was a topic-based health need assessment work. And within, I think, about 20 years or so, they did about maybe 20 documents. So it takes a long time to develop those guidance. So from the health need assessment work, I think at the same time, the new technology was coming onto the horizon, and there's a pressure on the government to fund those treatments. So then they established a separate health technology assessment unit. The NICE guideline, which is the National Institute of Clinical Excellence, it was developed and took over the University of Birmingham work, which they've been doing for previous 20 years or so. So NICE was created, and they also adopted the health technology assessment unit as well within over the time. So what has happened is the NICE, they've been producing the guidelines on the topics, not the individual interventions, because intervention will be the part of a health status, whether it's a kidney disease or the heart problems, hypertension, whatever. Right, so, and at the same time, there was a pressure on evidence-based medicine. So whatever we do practice, it needs to be evidence, it needs to be effective, and it to be the cost effective. So that is the foundation which has led to where we are now. So over the last 20 years or so, the NICE guidelines has produced more than 300 guidelines on different topics, and they cover all the issues, etc. So what I'm trying to say is that it's a long process, so you need a lot of resources. It's a multidisciplinary work, and it needs to be done at national level, if it's not at Emirate level, so it needs to be done at a much broader level to make it a more impactful and successful. So I think that's all I want to comment on. Thank you very much.
Thank you so much for sharing.
Thank you, Prof. Abid. You're right. I think this is a very slow process by itself. We are glad that we made the first step. We are glad that we already started one major building block, that is the AQ5D5L, I think, database or data set that is going to build up soon for the population in the UAE, on the basis of which we can then hope to see research on health economics in full-scale levels taking shape. Thank you. It takes time.
I think just to add on to that one.
Also, training. We need to spread the word. We are doing this within our postgraduate programs like the MPH, as you know, and you are very, I think you are making the greatest effort to see that this is happening. And we have it also on full levels at the PhD courses. So, I also do the same at the undergraduate levels. Now, all our graduates are taking at least basic introductory courses in health economics and in health technology assessments and so on. So it takes time spreading awareness about the health economics, about evaluations, about all that. And that's how people pick up the interest, the awareness first, and then the interest. And then I think it will expand over and over. Thank you.
Yeah, thank you. Thank you very much. I think that other thing I want to add was that obviously the focus on the new technologies. So that's interesting. And certainly we had pandemic and there were new interventions were introduced without any evidence. So that's why we had the research protocols for those interventions. So I think we have moved on in the UK is looking for the new technology, but also looking for the already existing technologies available and the old interventions, whether they're working or not, whether they're cost effective or not. And as a result of that work, the many interventions they had not part of the health system now. For example, removal of tattoos, varicose veins, removal of the tonsils in young children. So there are many interventions which were not, the cost effective or not efficacious, for example. So they've been removed from the practice. Yeah, great. So to keep in mind on the existing, the treatments and the technology as well. Thank you.
Yeah. Thank you. Thank you again. And thank you to everybody. I thank to our speakers. I think they came all the way from Dubai, from early in the morning. They got lost in the city until they reached us. And now 4 or 5 hours, we have been bombarding them with questions after questions, and they will. Anyway, thank you very much. I think you made our day. I'm glad to see Dr. Rami Beram with us. And Rami is a great wheel really behind all of this. And I would like to invite him just to say a few words, if you don't mind.
Thank you, Professor Mohammed, and thank you, Professor Grivna and the entire Institute of Public Health for putting this together, Dr. Affat and Dr. Azhar for organizing a great event. I want to thank all our speakers. My apologies, we couldn't be here earlier in the morning to welcome you. And on behalf of our Dean, Professor Jum'a Al-Ka'bi, we really appreciate you attending. And unfortunately, he wasn't here today either to come, but he sends his warm regards. And we hope that this is the first in many to come seminars that have to do with health outcomes research, which is a very important field that has started in the UAE, led by people such as Dr. Dalal and others who are pioneering this type of research here in the UAE. So we have a great team here in the IPH, and all the support is provided to them. And we're glad to see that the health authorities are also getting on board. We had a very fruitful meeting with the DOH yesterday and their HA health technology assessment team. And we look forward to collaborating with our collaborators in Dubai also and other health authorities to make this a reality that health outcomes research is used in the decision making when it comes to clinical practice. So thank you all very much again and welcome, and we hope to see you again soon here in person. Thank you.
Thank you very much. Can I ask you, Dr. Rami, we want to thank our speakers with this small token, and I would like to have you here to present it, if you don't mind, with Dr. Michael, and we can wrap it, please. Thank you so much. Thank you so much. Okay, so I'll leave it to Dr. Michael and Dr. Rami. So, yep. So, thank you very much, Dr. Mirna. So, yes, please. So happy. Yes. Yeah, and this is Dr. Mirna. So. So, Dr. Michael, do you want to say something?
No, I think already everything was said, so thank you so much for coming. We are really appreciating. I think we learned today a lot about the foundation of health economics, even about the health outcome measurement. about the HTA and how to build somehow bridges between academia and health authority. I think it is really great lessons what we learned. So thank you very much for coming, for having great lectures, presentations, and I hope, I agree with Dr. Amit that I hope that it is not last time, that it will be starting the continuation of our really fruitful collaboration. Thank you so much. And thank you everybody for coming, and also participants online. I think we had quite nice crowd online, so thank you very much for active participation. It was very good, and thank you for all organizers, Dr. Mohamed Sadiq, Dr. Ifa, Dr. Azad, everybody, Ismail and so on, who is behind the scene, Bayan and so on. Thank you so much.
Okay. Dr. Sarah, we didn't forget you. Are you still with us? I don't know if she's still with us, but this is when we see you and you come and visit us, we will hand it to you. So you need to come and visit us. Thank you so much. This is for Professor Michael. Thank you very much. Actually, it's for you because yes. Dr. Sadiq, he doesn't want one. No, don't worry about me. No, I don't know. I didn't want that. Okay. Okay, thank you so much, really. Let's take a group photo. Thank you, everyone.